My name is Wendy Bennett. I am an associate professor here at Hopkins in general internal medicine in the Department of Medicine. And I am really honored that I co-direct our center with Sabra Klein. So this is the Johns Hopkins Center for Women's Health, Sex, and Gender Research. And I want to welcome everyone to our 14th annual Symposium on Gender, COVID-19, and the Social Determinants of Women's Health. For those of you who are just getting to know us and getting to know our group, our Center for Women's Health, Sex, and Gender Research started actually in 2007. And we are a collaborative group. So we represent the schools of medicine, public health, and nursing at Johns Hopkins. And our goals are really around facilitating research, but also around mentorship and career development. And in addition to this symposium, we hold other events and we facilitate some of our signature programs, which are the Johns Hopkins Birch, and the Johns Hopkins SCORE programs. And we are thrilled that we are well supported by the Office on Research on Women's Health. I really want to thank Dr. Rosemary Morgan for organizing and bringing us all together for this wonderful symposium and wonderful event. I also want to thank Morgan Shearer, who is our program manager, and she has done so much work to make this happen today and make sure that this webinar goes smoothly. We're thrilled that this event is co-sponsored by Morgan State University and by the School of Social Work. And I want to thank Dr. Crystal Coles, who is an assistant professor in the Department of Social Work, and she chairs the Urban Children, Youth, and Family Specialization at Morgan State University. And she has worked really closely with us in planning and organizing this event. So without further ado, I'm going to pass this to Rosemary so that she can go over some housekeeping for today. Thanks, Rosemary.
Thanks, Wendy. Right before we go over some of our housekeeping, just wanted to sort of set the stage of why we're here today, and thinking about the people we brought together to talk about gender, COVID-19, and the social determinants of women's health. So we know that COVID-19 is a global crisis that has affected women everywhere across the world, and that there are diverse social, economic, and health-related impacts. With this in mind, we've brought together global and national inter and transdisciplinary perspectives to learn about these impacts and the solutions to respond to and address them. Panel 1 today focuses on the disproportionate impact of COVID-19, both here in the United States and globally. And panel 2 focuses on the solutions for an intersectional gender responsive approach to the pandemic, which includes the integration of diversity, equity, and inclusion, while focusing on solutions to the critical issues facing women during the time of COVID-19 everywhere. So we know if we are to adequately respond to this pandemic in a way that is responsive to the intersectional needs of women, men, and gender minorities, these global inter and transdisciplinary lenses are so important. And we're really excited that we were able to bring together a diverse group of people today to provide this lens. Next slide, please. So a little bit of housekeeping. This webinar is being recorded and will be available on the center's website. Closed captioning is available. You can access it in the bottom of your screen. Please do try to use the Q&A box for any questions that you might have today, although the chat box is open for you to write notes and messages. Panelists will take questions after their presentations. Do tweet what you are hearing and learning. And if you are tweeting, please tag us at JH_Women's Health. Next slide. So with that, I'd like to hand it over to Dr. Sabra Klein.
Thank you so much, Rosemary. I am honored to moderate this first panel, which will explore the ways in which women have been differentially impacted by the COVID-19 pandemic, as Rosemary pointed out, both locally and globally. We're going to highlight evidence related to the social, economic, and non-COVID-19 related health impacts. And so our panelists today include Dr. Rosemary Morgan, an associate scientist here at Johns Hopkins, who will be speaking about the impact of COVID-19 on women through an intersectional and international lens. Dr. Sabina Rashid, Dean and Professor at the BRAC School of Public Health in Bangladesh, will be focused on the impact of COVID-19 specifically in Bangladesh in women. Dr. Shannon Wood, an Associate Scientist, again here at Johns Hopkins at the Bloomberg School of Public Health, will be speaking about COVID-19 and gender-based violence in Ethiopia. And finally, Dr. Janine Clayton, the NIH Associate Director for Research on Women's Health and the Director of the Office of Women's Health, will be speaking today on the NIH perspective of gender, COVID-19, and the social determinants of women's health. So I would like to welcome Dr. Rosemary Morgan to share her slides. And the title of her talk today is A Never-Ending Cycle, COVID-19 and the Disproportionate Impacts on Women.
Great, thank you very much. So I am delighted to be here. Nice to thanks Sabra, Dr. Klein, for that introduction. And as she mentioned, I'm going to be talking about, the COVID-19 and the disproportionate impacts of women, but linking this to past pandemics as well, and how we are sort of seeing similar impacts that we saw previously. Next slide, please. So we know that there are disproportionate impacts of COVID-19 and COVID-19 measures on women, on men, and on gender minorities. These impacts refer to both primary and secondary impacts. The primary impacts are the more short-term ones related to things like infection rates, hospitalization, and death, while the secondary impacts are more longer term and refer to the social, economic, and non-COVID-19 related health impacts. And these are the ones we're really going to be focusing on today, the secondary longer term impacts. And what we're seeing is that women are disproportionately affected by these secondary longer term impacts across multiple measures. Next slide. So what are these different measures? Where are we seeing this disproportionate impact? We're seeing it in a lack of access or a reduction of access to sexual and reproductive health services, including maternal health. We're seeing it in an increase in formal care responsibilities within the home, whether that is looking after children or housekeeping type responsibilities, an increase in economic insecurity, including job losses, an increase in food insecurity, an increase in stress and mental health issues, increased rates of domestic violence, increases in teenage pregnancy, and negative effects on girls' education. And all of these are, of course, interrelated, these impacts. And we recently published a commentary in The Lancet on gender equality and COVID-19, Act Now Before It's Too Late. And this commentary, what we were doing is responding to an article that was published by Floor et al. in the Lancet, which in their study, they looked at administrative and survey data across 193 countries, and they specifically looked for data that was disaggregated by sex or gender, and found that women were disproportionately negatively impacted across a number of indicators, including the ones that I've mentioned. And we're finding similar things in our own research in the Gender and COVID-19 project. So in the Floridal article, for example, they found that women were more likely to report a loss of employment. This was across globally, across different countries. However, the largest gender gaps were seen in North Africa and the Middle East, and in Latin America and the Caribbean. Education, women and girls were 1.2 times more likely to report dropping out of school compared to men and boys. The largest gaps were seen in Central Europe and Eastern Europe, as well as Central Asia. And gender-based violence. We know that women were more likely than men to report that they perceived gender-based violence had increased. We saw women reporting increases in gender-based violence. And overall, if we're looking at regional variations, sub-Saharan Africa had the most pronounced differences compared with global data, while high-income countries had the smallest negative effects of COVID-19 across these different reported indicators. So the data and evidence is clear. Women and girls are being disproportionately impacted by COVID-19 and COVID-19 measures across multiple indicators. Next slide. The thing about this is we have found similar findings during past outbreaks. And this is a commentary we published in Nature that specifically looked at findings from past pandemics. And we're seeing a repetition of the same. We're seeing governments failing to respond to the negative gendered effects and not learning from this past evidence. We're seeing governments, only a minority of governments, collecting and sharing basic disaggregated data by, data that's disaggregated by sex and gender. And we saw it during past pandemics like Ebola and Zika, and we're seeing it again, and we saw it again in COVID-19. So during outbreaks of Ebola and Zika viruses, for example, women's socioeconomic insecurity was upended and for longer than men's. The same thing we're seeing during COVID-19. And what previous data showed us that while men lost jobs too, more women lost jobs, and while men tend to return to work quicker than women, for example. During Ebola, we saw sexual and gender-based violence rose in countries like Guinea, for example. And in the Democratic Republic of Congo, we saw sexual and domestic violence cases rise. We saw increases in teenage pregnancies. We saw more girls being taken out of school. It's the same story that we're seeing over and over again during Ebola, during Zika, and now during COVID-19. Next slide. So I've been thinking about what are some of the underlying reasons for this? Why are we seeing the same disproportionate impacts, and why aren't we learning from past evidence and past pandemics? So this is, partly why we haven't learned from past pandemics is likely due to the fact that these previous experiences of, in Zika and Ebola outbreaks, of where they were located, and the fact that they weren't as global in scope as COVID-19. And, COVID-19 has drawn attention to gender, unlike Zika or Ebola did. Another explanation, however, is due to the underlying and pervasive nature of gender inequality, which is compounded by patriarchy and other systems and structures of oppression. And the fact that during these crises, pre-existing inequities are magnified and reinforced, often with longer-term consequences than the crisis itself. And we're seeing that right now with estimates of how long it will take us to get back to sort of the gains we had in gender equality pre-COVID-19. These inequities were always there. COVID-19 just magnified them and put a spotlight on them. Next slide. I've mentioned that these inequities are shaped by different systems and structures of oppression, such as patriarchy and racism. And a term that I think encapsulates this is, and helps us to try to understand some of these reoccurring negative effects on women and girls is disaster patriarchy, which was written about V, who was formerly known as Eve Ensler in The Guardian last year. And this notion built off the notion of disaster capitalism, which was coined by Naomi Klein. And disaster capitalism is when capitalists use a disaster to impose measures they couldn't possibly get away with in normal times, generating more profit for themselves. While disaster patriarchy is parallel and complementary process where men exploit a crisis to reassert control and dominance and rapidly erase hard-earned women's rights. Racialized disaster patriarchy was actually coined by Rachel Luft before V or Eve Ensler in The Guardian. And she looked at this, she took an intersectional approach in relation to the response to Hurricane Katrina, and racialized disaster patriarchy really looks at the political, institutional, organizational, and cultural practices that converge before, during, and after disaster to produce intersectional gender injustice. Next slide. So in disaster patriarchy or racialized disaster patriarchy, women lose their safety, their economic power, their autonomy, their education, and they are pushed to the front lines, unprotected, to be sacrificed. We've seen this in increases in gender-based violence, women losing their jobs, food insecurity, women on the front lines as health providers, girls not returning to schools, increases in teenage pregnancies, and increases in child marriage, as well as female genital mutilation during COVID-19. Next slide. So what our experience during COVID-19 and past pandemics shows us is that unless policies and programs address underlying causes of inequities, including these systems and structures of oppression which reinforce pre-existing inequities during times of crises, we will continue to see women disproportionately and negatively impacted. Time and time again, policy and programming are failing to identify and address these underlying gender and other inequities. This gap is due to a number of reasons, of course. Gender power relations and other forms of inequity can appear in tangential or irrelevant to the desired outcomes we're seeing, particularly health outcomes. They can be difficult to identify, measure, and address, but that doesn't mean we shouldn't try. And they often are seen beyond the scope of our programs. But without addressing these underlying causes which lead to these inequities in the first place, not only will the disproportionate impacts on women that we've been seeing during COVID-19, as well as Zika, as well as Ebola, have lasting impact, but we will see a resurgence during the next epidemic or pandemic. So with that, I will say thank you and hand it back over to Dr. Klein.
Rosemary, thank you for those inspirational words. I am now honored to welcome Dr. Sabina Rashid, who will speak today about scarcity of life in Dhaka slums, fault lines in public health.
So good morning, good afternoon, good evening. Great to be here. I'm representing the Brack James C. Brown School of Public Health. So thank you, Rosemary. That was very interesting because I'm kind of building on that, but looking at it in the context of Bangladesh, where we're looking at informal slum settlements. And we've got of a population of 16 million in Dhaka, the capital city, which is quite densely populated. You've got about 5 million of informal slum settlements, which is people who've come into the city, either push or pull, looking for opportunities, cannot afford housing, and then live in these sort of settlements, pay rent, have to have cash going to eat, work, and survive. Can I get Morgan to help me show the slides, please? Thank you. So one is informal settlements, we call them busties, and we've got, it's really sort of congested. You've got 4 members, but usually 6 or 7 in one little space. It's shared facilities, erratic facilities in terms of water may come for a few hours. In some spaces, there is very little facility, so you have to walk somewhere or pay. There is no comprehensive urban policy in the country. The government worries that if you kind of have a policy, then they'll all start coming. The reality is that people come looking for jobs or opportunities. It's a little bit like looking at undocumented migrants. It's you pretend they're not there, or you persecute them. So they have insecure tenure, and the entire slum may be evicted, and then they're homeless, and then they have to look for another slum to find space in. But slums are not peculiar to Bangladesh. It's all over the world. Basically, any poor inner city, even though it might look different, suffers from the same kind of hierarchy of being at the bottom of the pyramid, socially, economically, politically. They tend to be, people who live in Bangladesh slums tend to be out of the economies of scale, socially, economically, and politically. So they rely on smaller networks to manage. And that's the case for most places where you have a hierarchy of privilege, power, and politics. Next slide. So we interviewed, this was longitudinal from 2020 to about 2022. We're working on a project with Rosemary Morgan and Denise and a couple of others, a couple of other countries, and looking at gender risks and vulnerabilities during COVID. But really, we selected respondents, not only we had large scale surveys, but respondents from the surveys, but also specifically from outside the capital city. And because it's focused longitudinal, we repeated our interviews to understand the situation for women. And we had interviews with men as well. And we have multiple projects at the school that also looked at the gender dimensions, but also structural inequalities and its impact on the poorest during a pandemic. Next slide, please. Thank you. So one thing, just to give you a bit of background, the government declared a holiday to do the shutdown in the country. They were worried and nervous about how it would be received. So they said, we're going into holidays, and the country shut down March 26th. I was in Bangladesh. We shut down our schools. We all went into isolation. There was a rigid lockdown. The businesses were shut down, schools, everything was shut down. Basically, the entire country, army and police were on the streets. Millions in the slums or the slum settlements were left without an income source because millions of them work in the informal sector, be it factories, be it domestic workers, be it bus drivers, be it running tea shops, be it maids. A lot of the women work as maids or garment factories. So it was a complete shutdown with no information. Most were worried about, what am I going to eat? And yes, I'm scared about COVID. If you notice the difference, which is very obvious, is that someone like me, I was worried about COVID. I was on Zoom. I was teaching on Zoom. I was working on Zoom. And for us, middle and well-to-do, it was the worry about catching the disease. But the one kind of public health message, one message that fits all, one we borrowed and adapted from the West and just did a complete lockdown, not thinking about the different population structures, the different human resource structures, the different, like we have fragile economies, we have inequities within countries, which is across all countries, but also the fact that we have different priorities and needs. So what happened was we just shut down the entire country, and a lot of people who live in slum settlements live day to day or week to week. So they already had loans, they already had debts, and suddenly there was a nationwide shutdown with no information about when it would reopen. And we started doing interviews in another project and follow up in this gender COVID project. We found that people were panicking. They were borrowing money. They needed to use their savings. They were selling their jewelry. They were selling whatever items they had because the COVID pandemic shutdown continued till end of May. Basic point here is for the poor, and it makes complete sense, is health is not just about disease inside the body. That's a luxury of many of us who live in well-off developed countries. And for me, who's well off, and I live in Bangladesh. So for me, it is about a disease and I need to contain it. For the poorest everywhere, and especially in Bangladesh, it's about how will we pay for food? I don't have a job. What am I going to do? The government keeps extending the lockdown. How will I pay rent? The landlady keeps asking me to pay rent. The slum settlements have landlords. How will I cover other costs? You know, the school is shut, but then what will my kid do? And they're at home now. So there was multiple kinds of stress and anxiety on poor families. And what I want to show is women, if we look at structural and social inequalities and equities, were very much affected. I'm not saying poor men were not affected. We have to unpack gender. Of course, poor men were affected if we look at intersectional factors of class, poverty, and socioeconomic status. But women bore the brunt and the burden of keeping some of their households going. Next slide. Shireen, you know, she talked about my mind's not stable. I mean, a lot of our respondents talked about getting into disputes. Main fear was what will we eat? Will we die? Is this the end? When will the COVID end? When will lockdown end? And in the middle of it, they'd also worry about contagion and stigma, because it was all over the news. We were watching, I mean, it was global television. People were watching what was going on in Italy and New York, even in slum households, and then they were looking at what's going on in Bangladesh hospitals, and there was just signs of, you know, people dying. Aki, her widow, who worked in a garment factory, but the garment factory shut down for 3 months, said, I have to worry about my next meal, and then worrying about Corona. You know, people, when you live a life of precariousness, and then it's magnified by these sort of policies that were very top down, very biomedical, did not look at tailor-made, customized policies for the poorest. You have a lot of not only anxiety, but basically it's about survival. Raja is a male, and he talked about his wife and him having anxiety. And he said, now the costs are increasing. My job ended up abruptly. One example for Raja, because he was earning better money because he had mobility, he suddenly went from earning really good money to now going back to the village while his family was in Dhaka to look for opportunities, prawn cultivation, and to keep coming and going. So families were upturned, upended. Life as they knew it was usually chaotic and precarious, but now it was just a fear of what would happen. Next slide. So with loans and debts, we found 19 out of the 28 women said usually they decided with their husbands about taking a loan, but women generally, 24 out of the 40 women said women are viewed as more trustworthy. They said that, so usually they're viewed as more trustworthy meant that they took on the financial responsibility for looking for loans. And they usually prefer to take loan money from banks or loan sharks, as we call it, because it was a fixed system. They knew those people in the slums. And yes, they had to pay an extra amount of money for every taka that they'd borrowed. So for 1,000 taka, I've only got a few more slides, Sabra, so I'm almost done. And then for every taka, you've got, you know, every 1,000 taka, you've got another couple of hundred. Next slide. So men were less likely to get loans. And as women said, that, you know, they assumed that men would flee or leave the country or they'd go into hiding. And usually another woman said it's actually all about social capital and network. In her case, she knew more people in the vicinity, in the locality. And there was a perception, which is not just a perception, a reality. A lot of men are into gambling and drinking, so they're unreliable and they may just skip out from one slum to another. So women were much more grounded with their families and they were more available and more reliable. So they took on that burden. Next slide about household. So I'm not going to go over this, but we know globally women took on increased household chores. And that's because there's this huge line of messaging around wash this, wash that, clean your utensils, do this, do that. But also women talked about children being at home. Ultimately, out of 12 women, 4 said that their husbands helped them, partially with cooking and cleaning, but the rest managed household chores also on themselves. So final point, which is my conclusion. Next slide. We need to move beyond the holistic approach to public health. It's a very biomedical, Eurocentric model we've inherited. Good health for the poorest, vulnerable, anywhere in the world, I would argue, but particularly for the poorest in Bangladesh, it's about having an income, it's about being able to eat, it's about paying rent, it's about not falling sick. Makes sense to me, given I can do all of that. It's about social capital and reliability, which means that for women, this doubled their burden because they were seen and viewed in a particular way. There was gender expectations and norms. And ultimately, we need to pay attention to and move beyond a biomedical framework. Finally, a socially just model in public health is critical. Otherwise, we're going around in circles, and every pandemic that happens, we overburden those who are vulnerable. Thank you very much.
Thank you so much. Our next panelist is Dr. Shannon Wood. She will be speaking today on gender-based violence in the context of COVID-19, a case study of violence during pregnancy in Ethiopia.
Hello, everyone. Can everyone hear me?
Yes.
Okay, super. So yes, I am here to speak today about gender-based violence in the context of COVID-19 with a specific focus on Ethiopia. I'm really excited to share this work primarily because it was funded by the center. So it fits really nicely into this symposium. So Rosemary gave an excellent overview of gender-based violence as a social determinant of health. And we know that 1 in 3 women globally will experience gender-based violence over the course of their lifetimes. Today, I'm going to focus specifically on intimate partner violence, or IPV, given that this is the most common form of gender-based violence, and really also thinking about the health impact of IPV. We know that this has tremendous impact on mental health, alcohol use, sexual and reproductive health, as well as death and injury to women. This work focuses specifically on IPV during pregnancy, given increased risk of miscarriage, premature labor, low birth weight, and maternal depression. This is also really important though, because pregnancy is a key time point for assessing and responding to IPV, given increased contact with health providers during antenatal care, delivery, and postpartum care. So thinking a bit about the COVID-19 impact on IPV, we heard very early on that pandemics could increase gender inequities, including IPV and access to support services. Notably, gender-based violence was pervasive prior to the COVID-19 pandemic, but there's a few specific pathways that this could work through. Increased economic insecurity, increased social isolation, exposure to perpetrators being unable to leave the home, especially during lockdowns. Also decreased options for seeking support during these times. I've highlighted a few really nice evidence trackers on the bottom here. There's a tremendous amount of work on this globally, but we see that overall IPV has been increasing globally since COVID-19. Today, this work focuses on Ethiopia. Our 2016 demographic and health survey data indicate that 27% of ever married women aged 15 to 49 had experienced IPV within the past year. Notably, Ethiopia is one of the few contexts where sexual violence is higher than physical violence. We also found that 4% of women had ever experienced IPV during pregnancies. So DHS only collects ever IPV data for pregnancy. And we know that help seeking is also tremendously low. 66% of women who experienced IPV never disclosed nor sought help. And this isn't, necessarily something that's exclusive or unique to Ethiopia, but most often women are seeking help from more informal sources of support rather than formal services. So this work sought to examine if and how the COVID-19 pandemic affected recently pregnant Ethiopia's women's experiences of IPV. And we did this through 2 aims. First, comparing the IPV prevalence pre and post COVID-19 using quantitative data. And then we also, the center generously funded a qualitative phase as well to contextualize women's experiences during COVID-19 through exploration of specific lockdown measures that could exacerbate IPV. So this work was all nested within the PMA Ethiopia study. We have both cross-section and panel surveys. This was specific to the panel survey, which follows pregnant women from pregnancy through their first year postpartum in 6 different regions that roughly cover 91% of the population of Ethiopia. So we do surveys at pregnancy, 6 weeks, 6 months, and 1 year postpartum. Our pregnancy or baseline data collection began in October 2019, which meant that when lockdown measures were implemented in Ethiopia on April 8th, 2020, it was approximately halfway through fielding our 6-week data collection. So that actually really nicely split our cohort into half of the women had been interviewed pre-COVID, and then the other half were interviewed after interviews resumed more in that June, July period, 2020. So we essentially were set up for a natural experiment. And so all quantitative data utilize that 6-week postpartum survey. So our exposure here is pre-post exposure to COVID-19. Our outcome is IPV. We look at this a few different ways: any IPV, any physical IPV, or any sexual IPV. And these are not mutually exclusive. And you'll see that we do this through Venn diagrams and a few different bivariate and multivariable logistic regression analyses. Then, as I said before, we have this add-on qualitative component where we did 24 in-depth interviews with women experiencing IPV, specifically in the SNNP and Oromia regions. These regions were selected due to high initial IPV prevalence. And so eligibility for these interviews necessitated completion of 6-week interview, consent to be recontacted for a partner-related interview, and then indication of IPV experience at that 6-week interview. We use semi-structured guides, inductive thematic analysis, and then matrices to look at their experiences. So here you will see that we have any IPV. So on the left, we have pre-COVID violence experiences, and on the right, we have that during COVID or post-COVID. Not that COVID's necessarily really over yet. But here you'll see that, in this pre-COVID period, 10.5% of women experienced any violence during pregnancy. And then this jumps up to 15.1% in that post-COVID period. And it's really a mix of physical and sexual violence. So here you can see this broken down in a different way. Again, overall, 10.5% to the 15.1 with an adjusted odds ratio of 1.51. So we are seeing increased odds of IPV during pregnancy in that post-COVID period. We then break that down and stratify by urban and rural regions. And here we see that this is really predominant. The association is much more predominant within urban regions. So it's increasing from 5.6 to 10.9 with an adjusted odds ratio of 2.09. And then in rural areas, notably, this is higher. IPV during pregnancy is higher at both pre and post-COVID time points, but it is not statistically significant. So we're not seeing this as a significant increase between the two time periods. But again, it is notably higher at both points. We break this down to look at any physical IPV or any sexual IPV, again, overall and stratified by urban and rural. Here we see that this is really concentrated for overall numbers of physical IPV and specifically in urban regions. And these other associations are not statistically significant, though again, quite high numbers when thinking about intimate partner violence during pregnancy. I do want to talk a bit about our qualitative data because I think that these are just really rich data in general. So women describe that husbands' loss of income or employment due to the pandemic specifically put stress on their relationship. And this specifically increased instances of physical violence within the household. They also talked about how COVID-19 had exacerbated pre-existing household tensions and how this also contributed to increased time spent together within the household. And this was really a stressor for increased violence during this time. Notably, however, many stated that the pandemic had little or no impact on the IPV that they were experiencing. However, previous violence that had persisted throughout this period. So key takeaway messages: IPV during pregnancy was prevalent and it was often severe. We did see heightened IPV during COVID compared to the pre-COVID period, and this was often concentrated in urban areas. And COVID-related stressors specifically may exacerbate this pre-existing IPV. So we have many recommendations, and we've been working closely with the Federal Ministry of Health in Ethiopia to think about ways to integrate this into COVID response, as well as continued IPV response within Ethiopia, primarily engaging with providers across the continuum of care, thinking about clinic-based aids, including World Health Organization recommendations for IPV identification, specifically during antenatal and delivery periods, linkage to health and economic referrals, as well as the use of safety decision aids so that women can learn more about their own circumstances and help assess their levels of danger and create safety plans tailored to those situations. I do want to end on the fact that there needs to be a continued focus on intimate partner violence and gender-based violence in general in the post-pandemic context. We very much know that gender-based violence is endemic, and it is absolutely wonderful that there's been so much focus and funding during this period, but it is likely to continue in the post-pandemic context. So I will end there. And many thanks to a tremendous study team for making this work happen, as well as our very generous funders. The first paper from this work is now out in BMJ Open, so I've put the citation for that there. Many thanks.
Thank you, Shannon. I would now like to welcome our final panelist, and then we will have our Q&A. So I encourage everyone to be writing questions. And just as a reminder, this is being recorded. I know there was a question about that. So Dr. Janine Clayton, Director of the Office of Research on Women's Health, will share NIH perspectives on gender, COVID-19, and the social determinants of women's health. Dr. Clayton.
Thank you so much, Dr. Klein. And I just want to acknowledge the Hopkins Center for Women's Health, Sex and Gender Research, and Morgan State University for this amazing webinar and my previous speakers. I'm going to take a little bit of a different approach than the previous speakers. I want to share a little bit of the NIH perspective and the interaction of sex and gender and in the context of COVID-19. So our mission is to expand women's health research, and we imagine a world for the first time where sex and gender are integrated across the biomedical research continuum and every woman receives evidence-based care. The way that we try to achieve that is through incorporating sex and gender across the research continuum, from that basic through translational and clinical, to advance rigor, discovery, innovation, and equity. And of course, if we need to have sex and gender analyses, reporting, and interprofessional education, healthcare, and all of that data informing health policy. The other way that we address this through ORWH, I just want to share a little bit about our signature programs. We're really excited that Hopkins has a BIRCH program, and about all of our BIRCH programs, there are 20 of them across the country, and their role is to increase women's health researchers. We have specialized centers on sex differences. We have administrative supplements on sex differences, sex and gender, as well as understudied, underreported, and underrepresented populations of women. And I highlight that one because we expanded that the scope of those supplements to include COVID-19. And then we have our R01 that requires a study of the intersection of sex and gender and health and disease. And so for today's conversation, I'm going to be framing my remarks more in the context of a biopsychosocial model of COVID-19 and its impact on women. And of course, from a biologic perspective, we well recognize the effect of sex there, and those have been briefly mentioned. From a psychological perspective, the last speaker highlighted the intimate partner violence aspect. Socioeconomic status, we have occupational exposures with the vast majority of essential workers and healthcare workforce being women, and of course the disproportionate burden of domestic workload that Rosemary mentioned at the beginning. But I do want to mention also that this interconnection of gender inequality, structural racism, and poverty, that interconnection has to be considered with the overlapping vulnerabilities, if you will, and that these convergence of factors, and I'm speaking primarily from a US perspective at this point, exacerbate system weaknesses that put marginalized groups at increased risk. So in terms of just weekly mortality rate ratios, I know there was a question in the chat a little bit about social determinants, and hopefully some of this will answer that. So this shows the estimated mortality rate ratios by state with Texas in orange, New York in blue, and the overall rate in black with Connecticut in green. And I'm highlighting this to show that there are disparities across the 50 states, and that very likely this heterogeneity of sex disparities across these different geographies and over the course of the pandemic suggests that there are a number of theoretically grounded hypotheses about the role of gender-related social factors in these patterns. And of course, gender-linked health behaviors could be part of that, as well as occupational exposures that interact with other socially salient variables such as race, ethnicity, and socioeconomic status. So in this study, they looked at health-related socioeconomic risks and vulnerability, and they found they were looking at relationships with mental health. Here, they looked at food insecurity, housing instability, interpersonal violence, and difficulties with utilities and transportation. And they found that before the pandemic, over 40% of women in the US had one or more health-related socioeconomic risk. And 49% experienced incident or worsening risks. And then by April 2020, the rates of depression and anxiety were twice as high as pre-pandemic rates, with 17% of women having symptoms of traumatic stress, and that the odds of anxiety, depression, and post-traumatic stress were 2 to 3 times higher among women who had at least one incident or worsening health-related socioeconomic risk. And that was a dose response that they identified there. In terms of what you're usually used to seeing for sex differences, you can look at the differences in COVID mortality rates, not absolute numbers, rates. You can see highest rates here in Indigenous populations, and then lowest rates here in Asian populations in the US. And then if you look at both crude rate and then age-adjusted rate, you see a slightly different pattern with Latinos, with age-adjusted rate having a higher proportion. So just something just in the context of the background of our mind for this slide, where I wanted to share with you some of the rare data that has sex, gender, race, and ethnicity by state. This looks at Georgia and Michigan. And what we found there is, people will say that there are higher mortality rates for men with COVID. That is what the data has shown, and the data are quite incomplete. But if you look at this data, you see that Black women's COVID-19 death rates in Michigan and Georgia are roughly 4 times, in Michigan, I'll just use that, 4 times higher than white men's rates, 3 times higher than Asian men's rates, and higher than Asian and white women's rates. So that these disparities, these here in terms of mortality, reflect existing health inequities and social factors. So these health risks are structured in complex ways that reflect systemic and broader social inequities. And so one of that pattern that my colleagues and I wrote about in the pandemic, we call this a collision of crises in the US. In the US, maternal morbidity and mortality exceeds that of our peer countries, and it's often attributed to race. But the reality is it should be attributed to racism because it is most related to social, structural, and environmental determinants of health. And so these women of color were experiencing these high rates before the pandemic, and the pandemic just made this much worse. And these intransigent disparities in maternal health are exceedingly high and completely unacceptable. So in terms of social determinants of health and the impact on mortality in rural and urban counties in the US, with these maps, you have infections on the left and mortality rates on the right, with the darker red being higher. The counties with the higher percentages of Black and female residents had the higher COVID-19 mortality rates. And they were associated with type 2 diabetes and HIV rates, which is not surprising. But for this conversation, I want to highlight also the association with unemployment rates in urban counties, and then also that higher education was associated with lower mortality rates, both in urban and rural counties. So that residential segregation and other economic factors need to be considered in these conversations as well. So of course, the healthcare worker turnover is something that's really important to all of us here. And 1 in 5 healthcare workers have considered leaving the workforce. 1 in 5 health workers in certain settings have left. In this study, almost all the respondents were women, and they showed the highest turnover rates for women with children younger than 5 years of age, and then the highest turnover rates for those who are Asian and American Indian, Alaska, Native Pacific Islander healthcare workers. I think that's really important to also look at different healthcare roles. The rate for health aides and assistants was 4 times higher than that for a physician. So if you look at the data, they say that we're on track to recover from this, but we have not recovered, of course, yet, and the pandemic is not over. So in terms of STEM and what we see in the STEM workforce, an area that I work in primarily, this publication looked at women who were publishing and women who were parents. And they found that women with children less than 5 years old had fewer work hours. So they had to reduce their hours more than parents with older children or no children. And so what did this translate into? Well, what we saw was that, of course, we saw women and first and corresponding author papers decrease, the submissions decreased significantly. We saw folks in that situation being less likely to accept peer review assignments, attending fewer panel review meetings, writing fewer papers, and that was not the case for those with older children or no children. And before the pandemic, even though in the United States, women represent half of medical school applicants, we know that there is a stark disparity in leadership, and women represent only 18% of department chairs and deans, have lower salaries starting, lower salary growth, and lower tenure earning potential. And this paper highlighted some of the things that could happen that would help to equalize this through promotion practices, scholarly productivity standardization, leadership, and recognition. And so I wanted to highlight this publication that Dr. Marie Bernard, Dr. Carrie Wolowitz, and Dr. Kelly Tenhagen and I recently put out in Nature Communications, where we highlighted some of the NIH efforts to address inclusive excellence. And so we focused on these 5 areas: enhanced flexibility options, the culture of inclusion, demonstrable leadership support, action-oriented accountability, and research and on interventions and best practices. I'd be happy to talk about any of these during the Q&A session. As I come to a close here, I do want to share some good news. Nature recently announced that they, in all of their journals, their portfolio journals, they will now be asking those that submit manuscripts whether and how sex and gender were considered in their study design. They will ask manuscript authors to indicate when no sex or gender analysis were carried out and clarify why they were not, and to note in either the title or the abstract if the findings applied to only one sex or gender. So we were really delighted to hear the Nature journals moving forward and raising the bar on sex and gender reporting and research. And so I'm just going to end here with the ways that you can follow us on social media, our publications, and our e-learning tools. And I want to draw attention specifically to the Women, Science, and Impact of COVID-19 webpage, where we highlight our materials. So thank you so much. And I will stop sharing and go back to Dr. Klein.
Thank you so much, Dr. Clayton. That was wonderful. I really want to thank all of our panelists for giving us a lot to think about, both with regard to social determinants of health, as well as how the pandemic has disproportionately affected women in diverse countries And I would ask that all of our panelists put their cameras on so that we can engage in a discussion. So we did have a question, I do think from Stella Perez. I do think Dr. Clayton did a nice job addressing this question explicitly, at least from the perspective of the United States. But I'm going to read it out because I do think it might differ depending on the country that we're discussing or working in. So how do you think you could measure the impact of social determinants in women with the mortality and complications of COVID-19, or maybe even in other diseases? So how do we kind of tease some of this apart? And it may differ depending on the country, the socioeconomic status, the education level, or where, as we learned in Bangladesh, where women are more likely to work. So I don't know, Rosemary, maybe you would like to start us off.
Sure, I'm happy to. Thank you. You know, that's a great question. And it's a good question because, you know, we know that data and evidence, you know, data has power, you know, what gets researched, what doesn't, what questions get asked, what don't, you know, and the fact that we didn't see, you know, sex and gender desegregated data for a long time, or, you know, even in the early days of the pandemic, you know, it was few and far between. It's better now, but probably still not as good as it could be. And it's the same, not just sex and gender, but, you know, bringing in the other intersections and bringing in race and other identities. And, you know, linking that to social determinants of health is complicated. It is tricky. And I take a gender lens in my work, and things that we do, for example, are, you know, breaking down or thinking about how gender power relations manifest as inequities, the different ways like differential access to resources, housing, food, income, differential practices and roles, differential norms and beliefs, and power and autonomy. And then you need multifaceted questions, you need the right tools and instruments, you need mixed methods approaches like Dr. Wood showed us with her quantitative and qualitative approach. And, you know, we've done this with other studies where we looked at the, you know, breaking down gender power relations, and then linking that to particular health outcomes and seeing where the strongest relationships lie. And I think you could absolutely do that with social determinants of health, and it needs to. And that's where we see those big inequities, especially that Dr. Clayton brought up, as well as Professor Rashid.
Dr. Rashid, would you like to address that?
Yeah, I just think Rosemary puts it very nicely, which is really this power politics and a paradigm in public health that allows for certain kinds of research that are predominant. It's not that it can't be done, but what you need to do is actually really first recognize that structural and social determinants are in fact part of health. We need to have those conversations about class, power, privilege, which we don't. We're uncomfortable. Also, in a gender panel, we need to unpack gender, which means poor men are vulnerable compared to well-off women like me sitting in Dhaka. So I think we need to kind of have a more nuanced perspective around class, intersectional factors. I mean, Janine or Dr. Clayton talked about race. In Bangladesh, it would be about class. In India, it'd be about caste and class. I think these are all very important questions. We're just uncomfortable. So I think the question is great. I think it requires us to unpack our own paradigms. If I'm very biomedical, if I'm a biostatistician, I am comfortable just getting numbers. If I'm an anthropologist or a sociologist, depending also on my perspective, I may or may not ask certain questions. So I would say, sorry, not to make it difficult, but we need to unpack our own location and positionality and our own biases that we bring to the table. And then, as Rosemary said, allow for interdisciplinary, but also political. I would bring in people with political science backgrounds, people with history backgrounds. If you really want to look at the historical roots of some of the poverty that's going on, it's a complicated question, but I think it can be done. One, public health has to move from its narrow model, but we also as public health researchers have to recognize the limitations. Sorry, but it's a complex question. And if we want to answer it, we have to recognize our own kinds of barriers and reproduction of also sometimes fault lines in public health in terms of knowledge. Thank you.
Oh, thank you. Dr. Wood, would you like to maybe have an opportunity to talk about how social determinants of health intersect with what you described to us with increased violence against women, in particular during the pandemic?
Sure, I'm happy to address that. I did see that Dr. Clayton's hand was up, so I didn't know if she was responding. Okay.
No worries. I'll go after you, Shannon. No worries.
Okay. So my work is similar to Dr. Morgan's work in that thinking more along the gender lines. So really, you know, what are the norms, the constructs that are contributing to violence against women? I love everything that Dr. Rashid just said in terms of thinking so much further upstream about politics and class and poverty. I think that in a lot of my work, we're often very crunched for survey space, that's always, you know, what are the most proximate determinants that we need to think about in trying to measure this. And so I also kind of work at the intersection of violence against women and sexual and reproductive health, which are very impacted by gender as well. And so some of the work, if you are interested in this area, the Center on Gender Equity and Health from University of California, San Diego, the Emerge website has a really nice work, like just they collect all the survey instruments basically on sex and gender and kind of break it down also nicely to look at psychometric scores and things like that. So if you are interested from a quantitative perspective, I think that that's a nice way. And you can't go fully upstream and look at everything. Look at what's already been done also, because I think that there's a lot of really good work out there. And then if you can supplement it with qualitative data, that's incredibly powerful as well. So.
Oh, thank you, Dr. Wood. Dr. Clayton.
I really appreciate my colleagues' comments in response to this great question. I want to add that it's really challenging when our structural factors don't support interdisciplinary research and transdisciplinary research. To just be very direct, I mean, NIH funds biomedical research, we do fund behavioral research, but that's not the vast majority of what we fund. And so when we put out, for example, the sex and gender R01, you know, people are like, well, why do you need to have gender in there? I mean, there's just a complete siloing in some circumstances of these perspectives. So conferences and webinars like this, where we bring together perspectives, are so important. And there are not a lot of spaces for those conversations. Dr. Rashid mentioned, you know, politics, anthropologists, I mean, other perspectives. That's so, I mean, COVID has made it clear that if we do not approach these problems in different ways, we're not going to be able to address them as they should be. So I did want to flag for colleagues here attending that we have a new common fund funding opportunity that's specifically focused on structural interventions for health disparities. You know, it's not just US based. And I mean, for NIH, a structural intervention is pretty uncommon. I mean, a structural intervention is like, you know, economic intervention or reparations, or, I mean, this is pretty unusual, but we are looking at the health consequences. So that's our entree into this space. And I just would encourage us all to make those interdisciplinary spaces available so that we can come together in new ways.
Thank you so much. Would you be able to put a link?
Sure.
To that common fund, and we will be certain it's there, but we'll also make sure that we spread the word. I think that's very important given our discussion today. And, you know, I think what I hear, or I heard from each of you, is how important it is to bring diverse people to the table, and also to educate those that maybe aren't at the table with us today and how we might be reaching into different sectors of our respective institutions in an attempt to increase the education about the importance of these issues, because I sometimes think raising awareness does help with increasing funding opportunities. And I see that Dr. Donna Vogel is with us and is very pleased to see discussions of interdisciplinary spaces. I would like to, in the Q&A, I saw that two different attendees have raised questions or raised at least a discussion about the UN policy statement on violence against women during the pandemic that was published in 2020. So I would welcome any of the panelists in terms of thinking about, and so I open it first to Dr. Wood to address what this policy statement said pertaining specifically to violence, but this concept of the pandemic setting women back, which I think each of you hit on in your discussions, and maybe talk a little bit more about the ways in which women have been set back.
Sure, I can take this one first. So just to say, you know, this policy statement did come out very early on, and I don't think that we fully understand the impact of the pandemic yet, particularly when it comes to violence against women. I mean, we're opening up in the US and many other places, but I think in some countries, you know, they're quite open at the moment, but they could see another lockdown or something like that. And there very much are economic implications of the pandemic that are going to continue to really just filter down. And I think that that's the hardest part, like in talking to colleagues, that it's very much shifted from the initial lockdowns to very much economic. In terms of setbacks, absolutely, there have been setbacks. I think that every person here touched on that, but I also do think that we're in a place that we don't fully understand the impact of that yet, and it's just going to be incredibly difficult to quantify that.
Anybody else? Would anybody else like to add anything?
Can I just add a quick point? I mean, I think we kind of look at the world in a disconnected way, but the global and the local are so interconnected. UN's funded by powerful countries. If powerful countries, certain countries go conservative, what I consider rogue, you've got impacts on women. I mean, look at, I don't know if we want to get into politics, Roe versus Wade. Why are we having these conversations? What does that mean for funding? If you look at what happened with COVID and WHO and it was sidelined, I don't think we can imagine these bodies to be so autonomous or powerful, because it's the entire structures of these institutions were set up to be independent in some ways, but in some ways dependent by the resources that are given. So I think we need to be realistic and remind ourselves of the importance of upholding these agencies and institutions, because they represent at least certain kinds of voices, at the same time recognize the conflict and fragility that we live in, that really endangers and jeopardizes the role of agencies and institutions, depending on who controls and who has a say. Thank you.
Barbara, can I add a slightly tangential point?
Absolutely.
So, not to minimize this point at all, very, very important point. But this issue of losing progress is across the board, not just in the IPV space. I mean, in the STEM space, in the health space, period. We're starting to see data on cancer rates with screenings, and how the screenings people haven't done their cancer screenings for a variety of reasons. Social determinants of health are playing a key role there too. But in the space that many of us are here in academia, I am very concerned about losing large numbers of women from science. I mean, obviously they themselves have, we want for them to be retained in science, but they change the science that we do. we change the conversation. So if we leave, which 1 in 5 healthcare workers are leaving, STEM workers as well, people can't get their research done, people have all these other demands, it's going to change the nature of the work being done. And that is very disturbing to me from a sex and gender perspective. Women are more likely to do sex and gender analyses. It's going to change the scholarship that we produce. We are not interested in going back to 50 years ago in terms of the scholarship. So I think that this notion that we are losing progress should be something that is across the board important to all of us, wherever we have an opportunity to intervene. And it's certainly something that makes me work even harder for all the individuals who work so hard for me and others to be in the seats that we are in, because that future generation, we have to make this space so that they can still stay into humanities, anthropology, politics, engineering, science, medicine, or it's going to change society.
I think that is so well said, Dr. Clayton. Thank you. I see one question that I want to put out there, and then I have a question of my own. So Anitha Morthy, who a graduate of Johns Hopkins, so it's wonderful to see her name. How should funders be thinking about investing in programs in a gender intentional way that goes beyond rhetoric and just merely collecting basic sex or gender and age related data? And then, what can academics and implementers be doing to really push this forward? So I don't know if anybody would like to start that discussion. Yes.
I go? Yeah, very quickly.
Absolutely, Dr.
Yeah, thanks, Anita. I really like your question. I think if you want to make funders accountable, let's just say, I think we have to first start with priority setting and conceptualizing what gender means and is implied as a lived experience in particular country contexts. It could be within countries, it could be across countries, because contexts vary. Disparities are uneven within countries and across countries. And I think that, and not to plug because I'm a medical anthropologist, but I find some of the most interesting work beyond basic sex and age data is to invest in social science research. A lot of the work we do is longitudinal ethnographies, qualitative, and it doesn't have to be 10 years. You can even do focused 3 to 6 months of where you get funding to have tools that are co-developed, co-designed in those community contexts to respond to some of the unpacking of gender as a lived experience, norms, cultural expectations, social. How does gender mean in poverty, class, socioeconomic? And I found, final point, is that I was part of the Social Science Network Alliance in Southeast Asia and South Asia. And we found that social science was hugely marginalized. It was all the epi and the bio, which is very important. Mind you, all my colleagues are epi and bio, but you have to understand the why and the how of gender. You have to understand what intersectionality is. What do we mean by structural racism or violence or inequalities? If we don't have funding, 1, 2, co-design, co-develop, which means it cannot be led from a top-down approach. Researchers from different countries need to work together and recognize there is knowledge and capacity and capabilities in countries like Bangladesh or other countries, and not being led by, to put it bluntly, North American researchers or UK researchers, European, who might be much more knowledgeable about their own country context. And sometimes research is very top-down led, north to south, and we've got silos of research where it's very biomedical, very quant, very numbers. So at every level, I want to make funders accountable. And at the same time, I appreciate, Dr. Clayton putting it out, this common fund for health disparities, because NIH is very clinical based. So this is a good move. I just wanted to say thank you.
Thank you. Before I get to another question that I see posted, would anybody else like to address Anita's question?
I mean, as the one funder here, I mean, I'm happy to say, people like me, there are more than me at NIH that agitate for addressing these fact issues, bringing social science into the conversation. We have an Office of Behavioral Social Science Research that's now recruiting for a new director. And so that person's going to set priorities, like you said, Sabina. Setting priorities is key, right? So we worked very hard behind the scenes to make sure that gender was included in the NIH-wide strategic plan for COVID-19 research. I mean, it could have easily not been included, I'm telling you. So, you know, we have to keep working hard to elevate those conversations and make those spaces. And then we appreciate support from individuals like yourselves who say in academic fora and other spaces how important it is. So lifting your voices, that is very important. Bringing up those conversations in our public meetings. So please do. And there was a question, do you mind if I answer that, Sabra? So about the funding opportunity I posted was the first one, Transformative Health Disparities. The new one, the future one, is called COMPASS. COMPASS stands for Community Partnerships to Advance Science for Society. And we announced that concept at the Common Fund Council called the Council of Councils several months ago. I was trying to find the right link for that because that FOA is not out, but we announced our intention to put it out, so that's public. So I will get you the right link for that. And if I can't get it before we're over, I'll send it to Sabra and Rosemary. But there's a new one coming out, even bigger than the other one. We even talked about how much money we're going to be investing over 10 years for these community partnerships to advance science for society with structural interventions to affect health. So really excited about that.
Thank you for sharing that, Dr. Clayton. It is very exciting. And, you know, I think for many of us who do try to bridge biomedical science with public health, this concept of going from cells to society and NIH trying to lead the way and be more intersectional is very exciting. I'd like to go back to a question from Dr. Coles that's specific to something that Rosemary defined and discussed for us about patriarchy and its impact on women. And Dr. Coles asked if Dr. Morgan could articulate more on how the patriarchy also acts to determine who and what is at the forefront of public health, and maybe even studied in terms of thinking about how that maybe intersects with the discussion we just had about what's fundable.
Yes, thank you. And thank you for that question. Yeah, I think, you know, a lot of what has been said sort of really highlights, highlights what I've been thinking about this concept. You know, patriarchy is really about holding and maintaining power, in particular male power in this, but of course we know intersects with other social stratifiers and identities. And it absolutely, you know, often in my own work, I think about turning the lens inwards about my own institution, my own research practices of, you know, we can't just look outward at our outcomes, at what we're hoping to achieve. You know, we have to think about our own processes, the inputs we're putting in, the processes and mechanisms that we're engaged in, you know, and how that might you know, exacerbate inequities or uphold power dynamics as well. And I think in a lot of these established institutions, you know, patriarchy has always been there. It's been very strong, particularly in the past. We see it in the fact that sex and gender has often been marginalized. We see it in the fact that social determinants, social structural interventions have been marginalized, and absolutely, you know, Dr. Clayton provided evidence of people leaving the profession and publications, and that we should be worried, because we should, because who has a seat at the table, it really matters. And these systems and structures like patriarchy, racism, manifest to affect who gets that seat and who is, going all the way back. It's not just about the point of who is most qualified and let's bring this person on board. There's all these things that come before that affects people's ability to even get there, and little things that, because of these sort of wider systems and structures. So, I think patriarchy, other systems and structures of oppression absolutely act to determine who is at the forefront of public health, what is important for us to study. Dr. Clayton mentioned there's very few deans of public health that are women. We have Professor Rashid is a dean of public health at the Brack School of Public Health. We have one of the very few here today, sharing. So it's, I don't know, Professor Rashid, if you have any insights of your experience having that seat at the table and thinking about what gets prioritized, what doesn't. And I think you've alluded to this already, because I absolutely think that this is important. It's important for us to put the lens inwards, think about our own positionality, and really making sure that we have diversity, within our own institutions. So maybe Professor Rashid, we'd love to hear.
Yeah, Rosemary, you're a part of that edited collection of talking about women leadership in global health. And while I have the privilege of class, as being pointed out to me, and I'm fully aware of it, it's a boys' club out there. I'm making a general statement, but I often find, depending on your positionality and location, so for me, being female in a very male-dominated academic environment, and that's the case in the US, in the UK, in Europe, because I've taught in other places, I've been there. And I was 44 when I was made dean, and I've been 19 years at the university. So at the end of the day, the uphill kind of legitimacy and credibility and voice, and I'm also a social scientist. So it really depends. And it depends on how many masculine attributes we take on as women and men and reproduce those attributes to our detriment or to our sort of solidarity, or bring in unity and support and create spaces for women. I'm not going to go on about it. It's not easy. And sometimes, and I would say this at a local global space. So at a local space, you can get shut out, silenced, or invisibilized. I'm older now, I'm 52. So people may listen to me much more now, and they do, but it was definitely difficult, and can be still difficult. In the global space, if I bring up issues around decolonizing, you can get shut out, invisibilized, and muted. So really, it's these different levels, but in general, patriarchy is very, very alive and present and subtle and not so subtle. And I think everyone's referred to this, but it's just, we also have to look at our own location and position and keep speaking out and taking risks and not muting our voices to fit in, because I've also seen, to put it crudely, we often kind of are not comfortable sharing uncomfortable truths. And I think that's important if we want to keep looking at what's going on now globally and everywhere else. Thank you. Yeah.
Well, thank you, Dr. Rashid. I think this ties in beautifully to another question that we've received, actually from one of my students, Patrick Creasure. Thanked all of you for a wonderful panel and was wondering if you could comment on how science communication can be improved to articulate or share much of what's been shown with regard to women's health, these intersectional approaches, social determinants of health, to just improve what our communities know and understand about what we're discussing today.
Anybody want to go there? I'll start.
Thank you.
I'm so glad that Patrick asked about science communication and that he's a student, because I want to encourage him to take advantage of some of the fellowships that exist on science communication. Research America has one specifically on science communication and advocacy. These are US based. The National Academies has one as well. They're short stints. And also I learned something from one of my students. She said, oh, Dr. Clayton, there's no fellowship on this, so I thought I would just make it up. I'm going to put this together for you and see if you think it's okay. Make up your own fellowship, figure, but it's so important, I think, just starting with the terms. We're conflating sex and gender. People don't understand what it means. Speaking in plain language wherever we go, being willing to talk to the media. I try to do that as much as I can. I'm sharing that with my colleagues, supporting media training for your colleagues so that they can get the skill. It's a skill like any other skill that we learn. And so, and then considering unusual media like graphic medicine. I mean, I had one of our social scientists said, would you consider graphic medicine? So just being open to that and recognizing it's a scholarship and a skill just like everything else and taking it seriously.
Thank you, Dr. Clayton. And I would welcome hearing from our colleagues working elsewhere around the world if those types of opportunities exist, and if media, including social media, is as open to having these discussions, hearing about these issues, propagating and advertising these issues.
Are you talking about media as in terms of the discipline and funding and investment? Or are you talking about censorship by the state? Sorry,
I'm
I
talking
wasn't clear
about
about the question. Yeah.
I'm talking about, much like what Dr. Clayton was pointing out, that there is an emphasis on trying to increase and improve science communication, including around these issues of women's health in the United States. Is there that same opportunity or even emphasis?
We have a Ministry of Women and Social Welfare, one of the few in South Asia. The challenge is we still have a very, and that's also global, I would say, very biomedical approach to public health. So while women are recognized, and we are one of the few countries that had specific laws around violence, specific kind of focus on intervention. So we've gone the other way, I would argue. All our interventions are very women focused. So which means I feel it burdens women to become suddenly active agents and enablers in their own life without having those conversations with other stakeholders around them. So they're kind of left to do this, to empower and change households and change spaces. While that's worked really well in family planning, microcredit, and certain public health challenges, I do think we need to bring in men, guardians, other actors in terms of interventions and invest in them. So it's not so lopsided that women feel so overburdened to take things forward. But that's in the development speak. And of course, there is funding around media and journalism and in terms of some of these issues. But we are not so great with data and data surveillance. We found that during COVID. And we also found there was censorship, but we're not the only country. I think US had huge problems with censorship around, what you can share. But gender remains invisible in terms of how gender is defined, depending on the discipline that leads public health. We had economists leading public health evidence in Bangladesh. So you had some conversation about women, but it was really about poor. Yeah. So it's really about who's leading it. And social science and gender kind of focus women, it's less and it's rare. It's not that it's not happening. You've got activists, final point, and women who are pushing it, and they're very, very vocal and very visible, and we work with them. But whether it's kind of nationally representative, no, because they're working on violence or certain issues which are important. But how about gender cross-cutting and throughout can get dropped off?
Absolutely.
Unfortunately, yeah.
In our last few moments as we end this session, I would welcome Rosemary, and maybe even bringing out this international gender and COVID group that you've formed, and how I think many of the issues that have been discussed today have been addressed by investigators in your forum.
Absolutely, thank you. So we and Professor Rashid is part of our Gender and COVID project, which is funded by the Bill and Melinda Gates Foundation. And we've been looking at how particularly women have been, the social, economic, and health related impacts on women and cross-cutting in 5 different countries. There's a larger network called the Gender and COVID Working Group, which has close to 700 members, and it's, it came about in the early days in 2020, really interesting. We published a commentary in the Lancet. We were only allowed 3 authors, so we put Gender COVID Working Group for the other people, and people kept coming to us. What is this working group? I'd like to be part of this working group. So we developed this working group, and it's really grown. There's a lot of subgroups. There's a very active one on gender-based violence. There's, one looking at intersectionality, one looking at adolescence, child marriage. It's really, really grown. We are sort of in a position of transitioning where we're relaunching, really wanting to be sort of collaborative, grassroots led. It's really kind of emerged from that approach. And it's really being able to bring people together from these interdisciplinary perspectives, global perspectives, very much what we're doing here today, to share experiences, to learn. And I think, our next panel is going to be on solutions to these impacts. And I'm really excited for that panel because, we've been talking so much about what these impacts are, and that's really important. We need the evidence. Evidence has power, data has power, as we've talked about. But it's kind of without the recommendations, without the solutions, without the interventions, it just sort of sits there, right? It's like we can use it for advocacy, but we need it to advocacy to move to action. And I think our COVID working group, we actually developed an action plan. It's such an important component, and I'm really excited about our next panel, which is sort of getting us to think about that for future thinking, solution-based approaches to the impacts we've just discussed.
I love that. Thank you, Rosemary. And maybe you could put the link to your website in our chat. And so with that, I want to thank our amazing panelists. I want to thank the participants for their engagement. I want everybody to be able to take a moment to stretch, eat, or anything you need to do for yourself. And we will be returning for our second panel at 11 a.m. Eastern Standard Time. So in roughly 27 minutes, we will be returning back together. So thank you again. Thank you. And we'll have slides rolling. So anyone who wants to stay on, please feel free to. Thank you.
Hello, everyone. My name is Dr. Crystal Coles. I am an assistant professor at Morgan State University. We want to welcome you back to this second half of the 14th annual symposium. This symposium is being co-sponsored by Hopkins and Morgan State University. We are looking for those that are new, welcome, and for those that are returning from the first amazing session this morning, we are hoping to be able to discuss a second half related to some of the topics that we were graciously introduced by all of the presenters earlier. So our annual symposium is called Gender, COVID-19, and the Social Determinants of Women's Health. You can go to the next slide. And as I was saying, I represent Morgan State University in the School of Social Work. I'm a social work researcher, and we are just so excited to be able to co-host and learn so much about what's happening with women in society throughout the world, not only here in the States, but internationally. I'm gonna pass it on to Wendy Bennett, who is gonna take care of a few housekeeping things, and then we're gonna flow right into our second panel. So we want to also encourage everyone, if you have a question or that you would like answered, please be sure that you utilize the question and answer link at the bottom, and we will be sure to answer your questions at the end of the panelist presentation. Thank you so much, and I look forward to talking with you later.
Wonderful. Thank you, Crystal. So for those of you who did not join us for this morning and are popping in for the afternoon, we just want to go over the housekeeping again so everyone's all on the same page. So we are recording this webinar. I know there were some questions about that. It takes us a little while to get it all up on the website when we're done, but then it will be available for anyone who wants to view it or share it. Closed captioning is available, and you can find that up at the Zoom options. For questions, we prefer that you use the Q&A box, and then we can access your questions, and we'll be able to go over them when we have the discussion after panel 2. And we and tweet what you are learning and what you are hearing, because we'd love to hear from all of you through Twitter. And please tag us at JH_Women's Health. So now we are going to move on to our second panel, which I am thrilled to be able to moderate for you. And we're really excited because this panel is starting to look at solutions, and we need solutions. So I'm going to let you know who's presenting, and then we'll get started. So panel 2 is focused on gender responsive pandemic preparedness, response, and recovery. We're going to start with Erica Rosser, who is a research associate at the Johns Hopkins School of Public Health, and then Denise Nassif-Pimenta, who is an anthropologist and researcher at the Oswaldo Cruz Foundation, and which is part of the Brazilian Ministry of Health. And then we're going to have Crystal Coles, who you just heard from, who is an assistant professor at Morgan State University and who is a social worker, and Sarah Key Price, who is a professor and associate dean for faculty development at the School of Social Work, Virginia Commonwealth University. So I'm going to stop my share to allow Erica to share her slides, and you can go right ahead.
Great, thank you, Wendy. All right. Is everyone seeing my slideshow? And can everyone hear me?
Yes, you are perfect.
All right, excellent. So I'm Erica Rosser from the Department of International Health at the Johns Hopkins School of Public Health. And since we've for those of you who joined us in the first panel, we heard quite a bit about the differential and disproportionate gendered impacts of pandemics. I'd now like to talk to you about addressing pandemics through gender responsive planning, and to give you some guidance on key steps to take and key resources that can be used when implementing activities. So let's start with talking about what is a gender responsive pandemic plan. A gender responsive pandemic plan is one which takes into consideration the intersectional needs of women, men, and gender minorities in planning data collection, response, and recovery. This includes considering and addressing how women, men, and gender minorities experience differential primary short-term and secondary long-term social, economic, security, and health impacts. I'd like to start by introducing you to a useful resource. Starting in early 2020, I began working with a team of international researchers, some of whom were part of the first panel, and you'll be hearing also from one of them from Brazil, who is a part of this second panel. We began working on a global gender analysis to provide real-time evidence to inform public health responses for COVID-19. So in addition to documenting and evaluating the gendered impacts of COVID-19 on our website, we have also collected a large number of relevant resources and communication outputs, including evidence downloads, briefs, and tools. One of the key tools that we developed is this brief, How to Create a Gender Responsive Pandemic Plan, which is a tool that can be used by policymakers, practitioners, and researchers to inform pandemic policies and activities. In panel 1, you heard some discussion about what might fall under some of the priority areas, like gender-based violence or livelihoods. In this presentation, I'm going to focus on talking about data, process, and partnerships. So to emphasize the action that is needed to ensure gender responsive pandemic preparedness, response, and recovery, we have outlined the steps to take before, during, and after an outbreak. However, as we've all seen over the past 2 years, pandemics are dynamic in nature. Cases rise and fall, there are breakthrough infections. So the process of integrating gender considerations into pandemic control is really more of a continuum than 3 distinct phases. But to talk a bit about pandemic preparedness, it is, of course, important because it helps to be able to respond more quickly in the event of an outbreak. But it's especially key to gender responsive pandemic management because it helps to avoid succumbing to the tyranny of the urgent, which tends to happen in emergency situations by maintaining a focus on predetermined activities and vulnerable groups. Some of the key steps at this stage include committing sufficient resources to respond to emergent needs and deciding on the strategic plans to address outcomes at different stages of a pandemic. So budgeting, planning, and then drafting policies to clearly outline and communicate set plans. Now, which of the 3 recommended activities stakeholders begin with in response efforts, implement, assess, adapt, it depends largely on how far along they are with their preparedness planning. But during response, it's important to monitor the effectiveness of implemented activities and programs so that you can adapt them based on the current epidemiological context, findings on process and outcomes, changes in the evidence base, and also inputs from representative partners and groups. Now, since the secondary impacts of pandemics don't end for everyone once the pandemic is over, during the recovery period, the types of programs and activities that will be appropriate might be different from the ones that were implemented during the pandemic, or they may be a continuation of the same responses. But during this time, it's key to carry out assessments at regular intervals so that policies and activities can be adapted and refined as needed when data is available to make the context more clear. And that is particularly important for vulnerable groups and communities. In addition to also focusing still on recovery, in addition to continuing to provide services, we should keep in mind that after a pandemic, we have an opportunity to build back better and to build or continue to support structures that take gender equity into account. I also wanted to spend some time talking about how important data is to developing, implementing, and evaluating an effective gender responsive pandemic plan. And I'll start by drawing your attention to the arrow at the bottom of the screen, showing the incorporation of intersectional disaggregated data collection should remain constant across all phases to maintain a focus on gender responsive activities. So the ethical and safe collection and analysis of multi-level intersectional disaggregated data is essential to having appropriate, equitable, data-driven pandemic control strategies and protections against the primary and secondary impacts of pandemics. These data-driven responses are also important because bridging the global gender data gap needs to be a priority to mount gender-sensitive pandemic responses. Epidemiological data disaggregated by social stratifiers like race, age, class, and sexual orientation, they allow us to identify and prioritize populations that are at increased risk for infection, disease, death, and the secondary socioeconomic impacts that tend to accompany pandemics. Disaggregated data can also give us a reliable basis for making difficult decisions about how to allocate limited supplies and resources. So an intersectional perspective can help to prevent discrimination and to improve appropriate implementation and targeted communication campaigns, for example. Reliable and timely gender-sensitive indicators should also be used to monitor the performance of pandemic-related services and programs. And then in order for this information to be useful, of course, there needs to be a feedback loop to policymakers. Another brief produced by the Gender and COVID-19 Project, measuring gender responsive pandemic planning, includes a non-exhaustive illustrative list of indicators applicable to several of the priority areas outlined in the brief, which should be given special attention during pandemics, including gender-based violence, economic and work-related concerns, and education. So these indicators, they're listed under each of these priority areas, and then they're grouped according to two thematic sections: dimensions of health and healthcare, and gender analysis domains and related subgroups. I also wanted to highlight that it's not just collecting data, but that a gender lens helps you to analyze that data in a way that takes into account vulnerable groups and intersectional needs. So we also need to consider how analytical tools can be used to promote gender-related considerations. So just to highlight two examples, the Gender and COVID-19 Project designed a gender analysis and COVID-19 matrix to highlight the interplay of gender domains of life, like access to resources, with different groups' experiences with responses to COVID-19 as it relates to risk, illness, and social and economic insecurity factors. So something like this can be a useful analytical tool to consider how gender dynamics influence experiences for different groups during a pandemic. Now, one interesting example I recently became aware of how something like this might be used is how the Standing Together for Nutrition Consortium, which is a group of experts in nutrition, gender economics, health, and food systems that study nutrition challenges related to COVID-19, generated an evidence-based analytic framework to inform recommendations to address the disproportionate impact of COVID-19 on women and girls' nutrition. So in addition to evidence, they used gender matrix analysis to map out evidence-based causal pathways for something like school closures and identify the impact of gender power relations on nutrition outcomes. And since, as we learned, we heard in panel 1, pandemic impacts aren't limited to the health sector, it's also important that partnerships be multi-sectoral, multi-level, diverse, and representative. Key questions to consider include when and for how long to bring in certain partners, if groups are adequately represented, and gender experts who aren't widely used can also be brought in to help build capacity for gender analysis. Just 2 more slides. Mapping out stakeholders, it's also a useful activity exercise that can help to make sure that appropriate partners are being considered across all sectors impacted by a given priority area. So some of the considerations would be what level of partner you can bring in. Each level will have different advantages and limitations. National level partnerships would have wider influence and impact, and local level partnerships would provide more insight into community realities, and also what type of partners you can bring in. So to highlight one example from Brazil, the Gender and COVID-19 Project, again, they highlighted work that was led by women in different districts of Brazil, where they engaged in collective advocacy and aid to support families faced with food insecurity by partnering with local organizations and expanding union support and working with local healthcare workers for mapping. So three key points to keep in mind for addressing the impacts of pandemics in a gender responsive way are to look for gaps and opportunities to include gender responsive programming at all stages of pandemic management, to prioritize the collection, analysis, and use of intersectional disaggregated data on a continuous basis, and to collaborate across sectors to find effective and meaningful solutions through multi-level and representative partnerships. Thank you.
Wonderful. Thank you so much, Erica. And we're going to share the next slides for our next panelist. So next we have Denise Nassif Pimenta, who is going to be discussing engendering COVID-19 in Brazil, health as a political choice. And thank you for joining us, and feel free to get started.
Thank you. It's a pleasure to be here today and be part of this interesting discussion. So I'm Denise from Fiocruz, which is part of the research department in the Brazilian Ministry of Health. And I also am a partner with Rosemary and Sabina and others and Erica on the COVID and gender project. And I coordinate the Brazilian case study, you know, along with other partners. So today I'm gonna talk a little bit in terms of solutions, right, that you were here to discuss. It's interesting that when we think of solutions, it's how we define the problems. So Brazil is an interesting case of what not to do or what doesn't work, and how the political factors have influenced the Brazilian response, and the consequences of trying to go against this, and all the actions that have been done against academia. And I'm going to talk a little bit about this. So next, please. So Latin America is one of the most unequal regions in the world in terms of wealth distribution. And as we know, as we've talked, COVID has been entangled with historical vulnerabilities and structural inequalities, especially for women. It's been said that capitalism and neoliberalism kills, and we're seeing that it kills particularly women, Black women or Indigenous women. And as you know, Brazil is a continental country, very big country. So the health systems have been working really hard to try and see different territorial specificities. And this is what we try to map, in the effects and impacts of women and other gender diverse categories. So as we know, according to race, ethnicity, and other class and social markers. And we've been seeing the use of this with the right extremist government. And how do we define how the pandemic is going? The use of data and denialism in the government, in all different sectors, municipalities, federal and state, and how we respond, and how the pandemic has been, the narratives around the pandemic, and if it's over or not, and who defines priorities and actions. So in Brazil, we've, over the last 5-6 years, we've had a huge political crisis with changing of 4 ministers over almost 3 years, and very unstable political climate, where you can imagine the changing and firing of health ministers during a pandemic. So this use of political and social markers from the government themselves into influencing the COVID response in Brazil has been very strong. Not only that, but in dismantling institutional organizations in the scientific, educational, and all sorts of sectors, epidemiological data, blackouts, and all sorts of censorship has also been seen. So Brazil has one of the biggest unified health systems in the developing country. It was inspired in the UK's health system in the 1980s, and it has health as a human right. And it's been a big fight here in the collective health area of sustaining health as a right. Next, please. So in terms of the pandemic, Brazil's been one of the epicenters. Today, we have 666,000 deaths and 30 million cases. But besides being a very big country, Brazil has one of the most famous vaccination strategies over time. And even though with all the difficulties of vaccination and access to vaccines and services, today we have around 68% of the country fully vaccinated, although with very big regional differences, and it's not homogeneous. The cases dropped recently, and you can see here the this graph here on the right is over the 2 years, you can see how the pandemic was by deaths case here in Brazil, and it's recently going up now again as the institutional have been taking off masks and no social isolation. So all of this has been coming back again now, and we are discussing the possibility of a fourth wave, and we're preparing for that. And one of the, in terms of women's health, maternal deaths were one of the biggest ones in the world. And well, 1,500 maternal deaths caused by 10% of the fatality rate in 2021. So we also have partners working with this. Next, please. So in all of these political climate, Bolsonaro, which is the Brazilian president now, has been assessed of crimes against humanities, and all sorts of political action is in the UN, and how race and different ethnic groups have been putting together civil society to fight against the political climate in Brazil at the moment. Next, please. So, so there's been many studies looking into this and how this affected the response in Brazil, and the use of the defense of collective herd immunity, the constant encouragement of exposure populations. There was no central federal plan for COVID in Brazil. So what happens was that the states and the municipalities took upon themselves to implement isolation and the use of masks and the different precautions actions. So you would see all over the country, different states with different actions of how to control. So this was a total chaos, right? And you had the systemic obstruction of governors and mayors, and the constant attacks and critics on journalists and press professionals, and many unlawful conducts from the presidency itself. So it was very hard during these past 2 years for different academic institutions and other to implement and try to control the disease in the country. So a team of researchers from all over Brazil put together an analysis of the political documents that were generated during the COVID pandemic in Brazil. And they saw that it wasn't incompetence or not wanting, not evaluating or not having access to data, but it was political will and the use of the pandemic for economic and political power. And this was an intentional policy from the federal government, and this has been one of the key studies used for the inquiry that was placed last year in Brazil. Next, please. So as was commented, we are part of the group, and some of the results that I'm going to present here is part of our results that we have many different actions and we work with different populations, but I'm going to focus here on some of our actions towards policymakers, because these factors of the political, how you deliver this data and how it comes about and who decides how to implement it, we found that this was very strong according to gender response. So we try to do this in all levels here in Brazil with the support of the group. Next, please. So there was based on our work with the health professionals and women health professionals, we were able to denounce in this technical parliamentary inquiry committee that was put together last year here in Brazil to talk about how women, particularly health workers, were not being assessed and were being many different violations. So our work helped prove how these health professionals, Black women from different regional, the peripheries of Brazil, were being mistreated and many other violations. So this helped implement some laws about this in Brazil. Next, please. As Eric had mentioned, we created some briefs, and this was an interesting experience because the group had an international brief that they put together, and we adapted this for Brazil. We put in Portuguese and also in a website with different languages for policymakers and academia and in the general population. So this is the importance of context, as it has been said by previous panels, on how not only the academia, but the partnerships with civil society and including social movements in research itself has also helped not only incorporate and represent these groups, but put them in the design of the research itself. So this has made all the difference in how we discuss priorities with policymakers. Next, please. So we focused on the social impacts. Our study were mainly qualitative data. And this book we put together in Fiocruz was discussing all of these socials. And it's part of a bigger network of social and economic impacts in Brazil. So we are the gender group that has been working on this. And this has also had impacts on different policies here in Brazil, especially inside Fiocruz, which is the institution that puts forward these gender and policies. Next, please. This is the work that I mentioned with health professionals. We did many briefs and we went on 5 different stages of online surveys. And now we're analyzing post-COVID and mainly mental health and the different social consequences of the work with health professionals. Next, please. And this is our work with the sexual and reproductive practices. And this is a huge project that has been integrated and into our work with the group from Born in Brazil, which is the biggest reproductive and health inquiry in the country. And we've been helping them out with the COVID analysis and with blogs and all different kinds of assessments of over 5,000 women. So this work will be used in other studies and trying to show how these pandemics were the civil rights. Next, please. Also, an important work were with health community workers, because here in Brazil, the implement of primary health is mainly through health community workers. So this was an interesting work that we also put together, and the importance of not going beyond COVID and thinking of other syndemic challenges with dengue and infected control and other diseases that were going on at the same time. So we've also been looking into these consequences and how COVID affected these other control actions. Next, please. This is the food insecurity brief that Erica mentioned. And also an important component is this, thinking of urban and rural communities, because here in Brazil, there's many different in how women leadership have been active in these communities. We're especially working with quilombolas, which is slave descendants. It's a specific group here in Brazil that has been shown attention of how they've been violating their human rights with access to vaccines and all sorts of, especially in relation to food insecurity. Next, please. Also, we've been working with oral history and trying to think of how elderly women were impacted in the terms of putting memory of how these registration of how these women, elderly women, suffered the pandemic. So we did a huge work with historians on oral history and the more qualitative data that is also important to put together a database of oral history, which has been really interestingly. We put together a collection of a book of these analysis and stories. We're also doing the terms of science communication of different videos and podcasts, so to try to dialogue with different areas of society. Next, please. So this is an interesting study that I would like to end with that came out recently showing how political partisanship and socioeconomic factors determine response in Brazil. And they did a huge analysis on 5,570 municipalities in Brazil. And they showed how the states and municipalities that were pro-Bolsonaro, the right government, had bigger death cases than other municipalities, showing how these political ideologies cannot be ignored in proposing control strategies of epidemics. So Brazil is an interesting case to see how this affects other countries as well, the US, the UK, but Brazil has been specifically, it's a good example for us to discuss a little bit about this. Next, please. But all is not lost. And we see how the importance of civil society in fighting against this necro-capitalist government and solidarity and all sort of creative actions and movements that were put together for people to survive, really. So this was we worked with a lot of social movements and trying to help them put this data forward and also put together these practices for policymakers. Thank you. Sorry, my English is not so good.
That was outstanding. Thank you so much, Denise. I feel like it also tied in so nicely to Erica's presentation, highlighting the importance of the partnerships. I was especially struck with the partnerships between the health professionals and the community health workers that you developed, and the ability to counter a lot of the misinformation and lack of information from the government. So thank you so much for sharing. I think it will tie in nicely with our next presenter. Crystal Coles is presenting. So we met Crystal earlier, and she is an assistant professor at Morgan State University here in Baltimore. And she's in her Department of Social Work there. And she's going to be talking to us about going beyond the data, connecting research to solutions. Thank you, Crystal.
Thank you, Wendy. Okay. Is it coming up? Are you sharing or?
No, I think, Morgan, are you able to share the slides?
Sure, I can share. Yes, 1 moment.
Thank you. Thank you, everyone. As Wendy mentioned, I am an assistant professor in the School of Social Work at Morgan State University. This is going to be a little bit of a different discussion because I started on a project, and the results of that project really led me to realize how much work we need to do just in developing research in itself. And so I want us to think about going beyond the data and really utilizing the process of research to also connect to solutions. Next slide, please. So one of the things that I had worked on with the student was really looking at telehealth and its impact to women of color throughout the time of COVID. We began utilizing a meta-analysis and looked at about 12,000 articles. Of the 12,000 articles, we really focused on having the articles address in some way, shape, or form women of color and their experiences, as well as areas related to mental health, interpersonal violence, smoking cessation, and so forth. And what we came up with were about 80 articles out of that 12,000 that identified an emphasis on women of color. And of those, it was about 25 that actually were useful in terms of things. And that made me realize we have a long way to go. So one of the things that was overwhelmingly apparent within the literature were that women of color and women in rural communities struggled increasingly utilizing telehealth options. Telehealth options here in the US were transitioned over and increased about 45%. There was very little training for providers to utilize telehealth services. It's been considerably promoted as cost effective. And what we're also looking at is utilizing this mechanism long term. And there are extensive issues related to equity. Many of us perhaps found it to be very helpful because we could utilize our appointments during the day and so forth. But for individuals who are disenfranchised, this was an issue related for equity related to the cost of the services, the access to broadband, patient digital literacy, utilizing being able to access forms and so forth. And then also reimbursement for services was problematic for providers. So as a result of that, it really led us to wanting to know more about telehealth with OBs in particular. And so we're in the process of a study to be able to sort of identify what has contributed to the utilization or to the lower utilization of telehealth services during COVID for women of color, more specifically for African-American women. We have completed about 18 of our 20 in-depth interviews with providers. And we are also in the process of doing our focus groups right now. And so this project, which I'm happy to discuss, led me to realize that there are many things that are not occurring before we get through the project. So many times we focus on discussing projects, what our findings are, and so forth. But what we're really looking at, if we're trying to make changes and shifts structurally, it really starts with how we're structuring our research. So I wanted to take a step back and discuss that. And my suggestions and our suggestions just related to being aware of how to have a social justice and equitable approach to the research we conduct so that you're being solution focused, not just at the end of research, but throughout the entire process. Next slide. So when we think about equity and social justice, one thing that needs to be clear is that it should be developed early on from the design. There really needs to be a shift in the utilization of the research methods and practices that we're utilizing, and they should really decenter whiteness. And by that, we really encourage people to utilize participatory practices and engaging in domains in all aspects of participatory practices, from making sure that your participants that are staff and caseworkers and et cetera are representative of communities, as well as those that are implementing the methods. Frequently, for example, I'm asked to be on projects, and I'm not asked to be on projects as an equal partner. When we speak about wanting to do equitable research and we want to gain access to communities of color, people come to spaces of color essentially to ask for you to engage, but to be the gatekeeper. And realistically, if you're not wanting for me to be an equitable partner in the process of research from design on, and you only are suggesting that we be your access point, then that really demonstrates what will happen with the community that I'm a gatekeeper for, which is why it's very important to note that I take that seriously. We take that seriously. Morgan State University is a historically Black college and university. And we want to be sure that every aspect of the process is equitable. And it is simply not equitable to ask for people to have access to communities of color and not allow for them to be an equitable research partner at the table. So we want to be sure that we are elevating the communities being researched, not just in the practice arena, but at the research table as well. It has to be an acknowledgement early on that research is not objective, neutral, or free from biases. Even the questions that are asked and so forth, they may actually not make sense in the context of the participants or the communities that we're working with, which is why it's important to be sure that there's a research representative that's connected to the community that can help us be sure that that is always at the forefront. These are the ways from the very beginning of a research project to ensure that there's equity and social justice being interweaved at all domains of research, including your findings and so forth. Next slide, please. So when we think about the implementation process, one of the things that's really important is there should also be a mechanism of giving back to the space. So oftentimes research goes into a space, accesses the community, and never ever gives information back or anything like that. Participants are a part of the process, and it's really important to have what you leave the community with a component of your research design. One of the things to consider is that stakeholders should be in a better space than when we leave them typically. For example, other processes to think about is in research designs that are with the community is what makes sense for the community. RCTs are great for us in terms of research, efficacy, and so forth. But does it make sense to the community? What is an RCT, and in what ways can you ensure that replicability, generalizability, and so forth, is it actually indicative of what's happening in that space? So it's this unique opportunity to connect your science with the people that it's supposed to represent. Also, aspect of being sure that data collection and instruments we are utilizing are collectively being representative of the community as well, asking, does this represent the community? Is this something that makes sense? Because oftentimes instruments are normed on predominantly white communities. And if that is the case, then there must be modifications that are made when we're working in communities of color. I think earlier we talked a lot about disaggregating data, because disaggregating data allows for the decrease of implicit biases. It also allows for the better representation of what communities of color are facing. So many times we say African-American, however, African-American is not monolithic. There are many subgroups of African-American groups within here. There are individuals that were born in the United States, and there are also individuals that were born from other countries that identify as African and as African-American. And oftentimes we're lumped together, and that's problematic. So that's an example of being able to figure out how to disaggregate this data to represent the collective differences between cultures and so forth. We talked today, I was happy to hear about qualitative method integration, and not just asking a couple of questions, but really integrating a method that gets at meaning, that gets at an approach to utilizing other ways of knowing, because when we are working with other cultures, there are other ways to understand things. Oral traditions and so forth are heavily appropriate in Indigenous communities and communities of color. And so being able to figure out, how do we navigate that? And how do we also be sure that we are creatively disseminating our data and including stakeholders in the interpretation of that data as well. Data is not for researcher to researcher, data is for everyone. And so we have a responsibility to be able to communicate what is happening within the process to the community stakeholders that we are involved with. Next slide, please. When we think about dissemination and we're thinking about something to consider related to it is how do we ensure that our stakeholders and participants are the primary audience? So oftentimes I'm a person that also and a researcher that utilizes federal funding. I'm a researcher that utilizes private funding. We have a responsibility to be able to communicate to our funders and disseminate towards our funders. But at the end of the day, it's the participants and the stakeholders that are our primary audience. We can, like being sure that we're communicating what those findings are in a digestible way, in a way that allows for them to have sustainability, in a way that allows for them to utilize that knowledge past the project that we're focused on is really important. It is, and I just want to reiterate, the community and the participants that are the primary audience, especially with regard to women and women of color from the spaces that we're investigating. I think also asking community stakeholders about their interpretation of the data findings. It's very rare that I've heard anyone say, well, we found out all this information about the women we researched and we took it back to them and asked, like, what are your thoughts about it? Because what are their thoughts about it? There's so many times we say, well, there's a lot of disparities and we have these social determinants of health and so forth. But if we're really looking at getting at structural issues, we have to also address the structural issue and the fact that people are not just there to be researched. They should be able to be a part of the process, and that knowledge should be theirs. So taking a look at the power of data and taking the look at how we can leverage data, not only for change in these spaces when it relates to policies and so forth, but to have a multi-systemic approach to it, and understanding that the individual, the participant, the community, and our other layers of government and so forth need to have information related to this. And so what is the responsibility of research once participants engage in our longitudinal studies and do all of these different things, making sure that they know what that means and is reflective of their space, because it may not be. It may be that we ask the wrong questions. It may be that this is great for our external partners and providers and funders and so forth, but if it's not meaningful to the population, then how are we to get at structural issues? How are we to address solutions and identify solutions, if not with the people that it's meant to be about? We know that there's significant power in data. Data is money. Data, on this call alone, we heard about millions of dollars that are being invested in figuring out what solutions are at structural levels and so forth. That is significant power, and we can leverage that power for change. There are ways to be able to gain the funding, apply the technologies and methods and so forth that we utilize, but also to do it for a space of change that is actionable. So we're not consistently talking about all these things, but making changes as well. I also suggest that data and results can be leveraged for good and not just publications. Publications really speak to us. And I love talking to all of you. And I think we love talking to one another and engaging in our processes and so forth. However, we have to think about how to leverage the good that we're learning from that in dissemination that is not just meant for those publications and so forth, because that in itself, in terms of accessibility, is an access issue. That's an equity issue. You can't access some of the things that we publish if you don't pay for them in certain spaces. So considering that, the other thing that I like to identify is what's called the so what factor. So once we've done all of our research and once we have the results and the outcomes and we have done something to perhaps give back to the participants and stakeholders that were involved, then what do we do with it? And thinking through what solutions really are. Solutions are meant to make something better. Solutions are meant to address the issues. The pandemic impacted communities of color and women in an aggressive way, but as many people have identified today, that was already happening. The pandemic just exacerbated it. And as a result of the 12,000 articles that we reviewed and of the ultimately 25 that identify the experiences of women of color, there were no identified solutions as related to what to do about these disparities. And I think that we as researchers have a responsibility to do more and to always be focused on moving that needle forward. So what I wanted to kind of say is, you know, these things are connected because it's as I am a researcher and a woman of color and a woman that is represented in a lot of spaces, I'm also a woman with access. And when, as a social worker, one of the things that we do in social work research in particular is just to push things forward a bit more and to be authentic in the processes of how we're able to do that. And so I wanted to talk, again, I'd be happy to talk about the project and that's fine, but I wanted to suggest some other things because I think we just have a stronger responsibility that needs to be acknowledged in the research that we are conducting. So I want to thank everybody for this opportunity. Yeah, and it's been, and I'm just interested in your thoughts regarding this.
Yeah, thank you so much, Crystal. I thought that was such an important perspective for this panel in particular as we try to identify strategies and interventions and approaches to really think about positionality and even to think about who's at the table and how we have our partners truly at the table as we're moving forward with these new strategies we're testing in research. So thank you. I think that was really important. So next on our panel, we have Sarah Key Price, and Dr. Price comes from us from the Virginia Commonwealth University, where she's a professor and associate dean for faculty development at the School of Social Work, and is going to be talking about interrupting isolation, reproductive loss, mental health, and post-COVID intervention. Thank you so much for joining us.
Thank you so much for having this talk today and for inviting me to be on the panel. It's made me realize how much I miss Dr. Coles and working with her. So I want to thank you for that wonderful presentation. What I hope to do just in a few minutes to close up this panel and open up some conversation is to add a lens of reproductive justice and awareness to our gender responsive pandemic preparedness, response, and recovery discussion. My research career has been working with women, families, and communities who are disproportionately experiencing fetal and infant mortality, and therefore the idea of reproductive loss, the mental health repercussions of pregnancy, and the then overlay of the COVID-19 pandemic has significance for the people for whom I've worked in my career. And I was deliberate in thinking about this. I didn't want to say post-COVID because we're still, I think, as Dr. Rosser so well pointed out, there's a cyclical nature of our pandemic response and recovery. And particularly for pregnant people, this is a repeating cycle where there's been a lot of overlap in terms of worry and mental health, anxiety, and loss. So I want to talk a little bit about that. First of all, I just want to put into perspective the fact that we know some things and we don't know some things. We know in a very recent study that was published in JAMA Pediatrics that there is an increased risk of pregnancy complications and negative adverse neonatal outcomes, including preterm births that have happened during the COVID-19 pandemic. And that was in a multinational study. But we don't yet, we're just beginning to have the magnitude of data pertaining to fetal and infant mortality to really know the impact of the pandemic in terms of the health and well-being of pregnant people. We did, according to the most recent CDC data insights, see a slight increase in fetal mortality. And again, that's reportable fetal mortality, because we do know, as I'll talk about, that sometimes reportability is truly an issue when pregnancy loss occurs. For people who are pregnant and have been pregnant during this time of pandemic, there has been increased physical distancing both in the initial lockdown phases and ongoing because of vaccine restriction and or hesitancy, particularly during the time of pregnancy. And there's a lot of public perceptions as well as medical advice and what we don't know that impacts people's willingness to receive vaccinations or boosters during pregnancy. We know that there's an interdependency of grief and trauma in individual lives. And we have seen, as Dr. Clayton so well pointed out earlier this morning, that the social determinants of health are attributed to racism, not race. And that we have seen the response of racism impacting similarly our responsiveness to fetal and infant mortality. As a result, some of the pregnant people that I've been working with and in provider organizations and with other researchers working with this population, we note a heightened experience of vulnerability, which is not going away. And in fact, which may continue to impact the mental health and well-being of people during and around the time of pregnancy. I want to add on to that an awareness of compounded isolation. Pandemic safety has been at the front and foremost of our conversation. And that means for the pregnant or vaccine hesitant, that has been a hesitancy to utilize medical services. As Dr. Coles pointed out, there's also some challenges in terms of telehealth and telemedicine in her study in terms of accessing prenatal care. And so there are some risk factors in the system that may lead to some heightened vulnerability favoring pandemic safety over other recommended health, preventative health actions. Medical system access and stress has been significant. If you are concerned about your vulnerability to COVID-19, going to a public clinic waiting room is probably not going to be top on your priority list. And so the stressors of seeking regular and routine prenatal health care and or mental health support are noticeable. I would credit physical and social distance as well. And particularly for people for whom have experienced a pregnancy loss, social distance and the social distancing from others to normalize and validate their experience has been a significant factor. Isolation is compounded by the stigma that already exists surrounding reproductive loss. Every time I've given a talk, and maybe there's even someone in this talk today, even if it's a very data-based talk that I'm giving, almost inevitably someone will tell me about a reproductive loss in their own life or someone that they love that they haven't felt able to share about. We still have a considerable amount of silence and stigma pertaining to reproductive loss, as well as to mental health. And that's compounded by racism and the way in which we expect people of color to rise above, or we have presumptions that we hold about people's response or about the normalization of experiences in groups. And so these two work hand in hand against being able to fully access the help that people may need and deserve to receive. I want to also note, and I'll talk about in my solution-based slides, that moral and legal sanction are also at an all-time high. Coexisting with this pandemic has been our pandemic of recognized racism, our social policies seeking to legislate reproductive autonomy, and those moral and legal sanctions placed on people who are pregnant in terms of what they are to do, what they should not be doing, how that pregnancy is lived out, are also at an all-time high, making this a very particularly precarious time. I want to focus mostly though on some strength-based strategies, because I do think there's things that all of us can do, whether we're researchers, whether we're practitioners, or whether we are human beings working with all the people who are around us. As a social worker, I think about the multi-systems of intervention, and I would like to note that on an interpersonal level, to assume that loss has been present and that mental health has been impacted during the pandemic is probably one of the best things that we can do. rather than waiting and asking and wondering how often this has occurred, assume that those people who have gone through pregnancy or are contemplating pregnancy have experienced a degree of loss. Just like we have a trauma-informed perspective, I'm asking us to have a COVID-informed perspective and to assume that there have been impacts at this time related to pregnancy and reproductive health and mental health. On the familial system, recognizing role strain. In the pre-pandemic times, it was hard enough to have social networks, but many people moved outside of the family system with grief support, would talk with colleagues and coworkers. Now, as we know, our workplaces have been very disrupted in many ways. There are fewer opportunities for people to have naturalistic conversations or to receive support from wider segments of their work, collegial, family life. Their immediate family is being the ones who are impacted by the loss, and they're also holding onto losses or working through mental health challenges. And the familial relationships as a result, whether that's a primary partner relationship or immediate family relationship, are experiencing increased amounts of role strain, taking on all of the caregiving, emotional caregiving tasks, as well as being present and maybe personally impacted by a loss or mental health during the pandemic as well. In the social and cultural system, we are able, in a strengths-based perspective, to center relationship building. One thing that we've learned in this time where there's increased virtual spheres is that we don't automatically virtually engage. We get to business. There's less small talk. There's less ability to actually build networks of intentional community because the intention is so focused on when people come together and what the task is. So thinking about the ways that we can increase social and cultural communication amongst people, whether that's in person when it's safe to do so, or using virtual networks, is also an important way of thinking about community. In community, there's more ability to talk wholly about one's reproductive experiences. But right now, a lot of the loss that has been experienced in people's reproductive lives has gone without any kind of intentional community support. And finally, in the policy and legal, the macro system, we as public health professionals need to confront and disrupt some of the public debate and the public concern that's expressed around the health and mental health impact. And this particularly includes legislation right now that would limit reproductive options at state levels, as well as the actions of the Supreme Court. We need to think about this not as just an issue that is an issue about abortion in that politically charged term, but to think about the fact that the reproductive health networks and systems of care, health and mental health, depend largely on options and choice and informed decision making. As limitations are placed on that, we also limit the networks that are available to be able to provide reproductive support. It's a severe blow to reproductive justice, irrespective of whether or not the pregnancy is wanted and intended to carry to full term. We are about ready to enter a time where our reproductive health networks could be decimated. So moving forward, how do we address some of these things in our work? And I would love to have conversations with you about this as well. I think one of the things that we can do, and we've heard repeatedly today, is that we can work across disciplines to create community-based informal and formal support alliances. There are places in the community, and there are ways in which the community is trying to care for each other. And in that mutual aid, which is to be honored, centered, and respected, there may be ways that we in our disciplines can advance the mutual aid that is existing to be able to provide additional support alliances and structures through funding, not through replacing programs, but through supplanting and making sure that enough resources are distributed to mutual aid groups. We can recognize the prevalence of unmet mental health needs amongst those for whom are included in our research samples or who are in our public health clinics. And we can assume that mental health support should be offered on a positive, proactive basis, not only waiting to see the negative impacts of that. We can work and do further work to co-locate health and mental health support services, particularly if we find ourselves in the situation where we have limitations on and reductions on the funding available for reproductive health services. We need to think of ways creatively to bundle our care so that we're caring for the whole person throughout the time of pregnancy. And finally, I would urge you to disrupt some political rhetoric that we hear happening by focusing on reproductive justice. Reproductive justice centers not only the rights to reproductive choice, but also the intersectional need to focus on the roles of racism, sexism, heterosexism that are prevalent and that can really impact reproductive choice on a more global scale. So I introduce these things as part of the conversation today, and I look forward to our continued dialogue.
That was wonderful. Thank you. And what a great way to end this second panel and to start our discussion. So I wanted to see if all of our panelists wouldn't mind turning your cameras on so you can join us. And if our participants want to start putting some of your questions into the Q&A, that would be great. And then we could bring those to the panelists. I'm going to start with a question already from one of our panel one panelists. And I'm going to build on it a little bit as well, because I had a similar question. So across all of your presentations, you talked about the role of community engagement as an important theme, and thinking about how we could really leverage these partners to address the disproportionate impact of COVID on women in particular. And I want to build on that a little bit by also asking you to think about what Dr. Clayton brought up, where she was able to highlight for us this wonderful new research opportunity around advancing health equity, supporting that partnership. So supporting research community partnerships. So as you think about the value of community engaged research, community engaged work that we're doing, if you also want to think about how, what are the partners needed? Where are the research gaps? Where, who should we be partnering with? And where do we need evidence so that we can have better dissemination of this work to really, find solutions to what's happening with the pandemic, but obviously beyond as well. So, let's see, who would like to go first? And I think each of you might want to address this. Does anybody want to start, or should I call on you in your order to think about community partnerships? Erica, do you want to start, since you were the first one to actually bring up the need for partnerships as part of the preparedness and response in the framework you discussed? Do you want to start? And then we can maybe go down our list and end with Sarah, who I know, that was sort of the majority of your presentation, which was excellent. So go ahead, Erica, why don't you start?
Sure. It was really interesting for me to listen to the examples that everyone else had about partnership and the discussion about engaging with local communities. I think one of the key things to keep in mind is that people are already doing work. I think especially in communities where there is a lack of resources, we find that there are people that are already engaged. They're helping to fill those gaps. And one of the things that we should be doing is looking for those leaders. And a number of the examples that I think we all brought up, they tended to be women leaders. So looking for the leaders in those communities and then finding ways to support them in the work that they're already doing, because they're there, so they know what's needed, and have some good ideas about how to go about implementing solutions.
I think that's excellent. Denise, do you want to Do you want to add on?
Sure. That community engagement is a huge theme for us, and not only with what we label as community, but even inside researchers and academia ourselves, and with civil society and NGOs, and the different interests involved. And with our experience here in Brazil, we find with the Zika epidemic and other epidemics that we're constantly battling, that trust is fundamental. And past work with these communities and who knows who and leadership. So all of these things are very subtle and not objective. So this has been very interesting in our work with COVID, and even in our research community ourselves, and considering that we're also community and how we label and differentiate between who's the other and who is being researched. So so trust is fundamental. Leadership and fonts, information. Who do you get your information from? And how to listen, how to bring up questions and really listen, because sometimes we go and we propose problems and the community has other interests. So to come into a middle ground and negotiate, and this takes time, right? In social science, we need time and sometimes funding and projects. For example, now we're coming in with loads of qualitative materials for the project, and the project is finishing in June. So all of these aspects intertwine, right, with how we not only work with people outside academia, but how we think about it. And also I would like to question a little bit the idea of what we consider solution, right? Is it the end of disease? So if there's no more COVID, is everything okay? And the whole biomedical idea of health promotion going beyond the end of epidemics or disease-focused strategies. So very complex, no recipes, right? I think this is also important because the whole biomedical area gives a lot of recipes of what to do, what works, and this isn't true. Context is fundamental, trust relationships, and what how institutions have legitimacy is also very important with science communication and public engagement, because certain institutions, like for Fiocruz, for example, has a lot of, so this was made easy or easier to dialogue with the media and how, but also how to disseminate qualitative data is also very, very complicated because the media is used to quantitative data and how to express more subjective impacts, like Sarah mentioned and Crystal. So it's a huge challenge and we learn every day.
Yeah, no, I appreciate that. Crystal, do you want to comment as well on having community at the table and even research opportunities?
Yeah, I think Erica and Denise have brought up excellent points, and Sarah obviously as well. But to build off of it is mainly, I think, knowing your landscape, and landscape means going beyond the primary orgs and being involved with community leaders. I think that the idea related to solutions, like, I think we so often can think of a solution, but it's not our community. And it's the community that needs to identify what those solutions are. So many times in community-led work, we have to have a level of patience because we can develop an excellent design. And then when you go to implement it, it just blows up, and it needs to, because it needs to really fit them. But I think knowing the landscape and knowing your access points is really important, and building rapport. Communities do best when they trust you and have rapport. Rapport takes time. I've been working, I do community engaged work in general, and I work with a lot of organizations, but I work through communities. So I work with a lot of neighborhood groups. I work with neighborhood centers. And I go to neighborhood meetings and I sit there, and I did that for a year when I was moving first here, just so they could see my face and trust that I was invested. And I wasn't the type of researcher that was just coming to engage and leave, but the type of researcher that was invested in the cause that the community wanted. I think also being led by, once you have the trust and rapport, they will lead you to where their gaps are, and then you can design based off of that. So my suggestion is really having the patience and having the authenticity to work with people in conjunction with what their needs are, instead of predetermining things before engaging with them.
Yeah, Sarah, I'm really interested to hear from you, but I wonder also if you might highlight how you discuss the stress-based strategies, and as we think about community partnerships and research, whether there's an opportunity to test and evaluate, how we use some of these strategies, through the community-engaged research that we're doing.
I think that there is. I think that's a great way to spin this. One of the things that I've learned about with community, and I'm going to echo everything that Crystal said, and say that authentic presence, is the trust building thing, because that's when we all begin to have conversations with each other, and then it doesn't become a tug of war between who has what ideas or where does knowledge reside, because knowledge resides everywhere. I may have knowledge that I've acquired as an academic, but that is not more meaningful than the knowledge that people have acquired in their lived experiences in community. So when we're sitting together authentically, like having a conversation, like we're having a conversation now, but we can have conversations and questions will emerge, and we can talk about some possible things or strategies that have been tried elsewhere, interventions that we've heard about. But I offer that with a caveat of saying, I've read a study that's conducted in whatever location or multiple locations, and I don't know, what do you think? Like, is that something that could have relevance here? How might it look different, or how might it be not, appropriate or not appropriate altogether? And just having that conversation and that dialogue with community who are the experts on their own experiences helps us get to a point where we could test something out. And sometimes that, you're exactly right, it doesn't have to be the full scale RCT that is the next thing we do, but a testing out of something in a smaller situation is really a key to both building trust, as well as, I think, to do an authentic research that may be relevant and responsive culturally to the communities that we're working.
Yeah, no, I think that's helpful. I'm going to shift gears a little bit. There were 3 questions that are really tied together in the chat, focused on care, particularly using primary care as a strategy to enhance health and wellness, and how that can specifically be helpful for women as well as others. And then somebody also talked about teams, so care teams like family, doctor, nurse teams, for instance, and whether there's opportunity for using primary care and these team-based approaches to improve healthcare for women. And I'm curious, actually, to start maybe with Denise, since maybe you can highlight a little bit about what might be going on in Brazil with community health workers and partnerships that you all have with health professionals, and the infrastructure of primary care there, which I would find really interesting to hear about. So go ahead.
Thank you for the questions. Yeah, so Brazil has a very interesting unified universal health system. It's free. So this was fundamental for the COVID response in many ways, not only because there was an absence of a federal recovery or even action plan, but because it's decentralized And so the municipalities and states and primary healthcare was very intertwined in offering services and the testing, then vaccination. So this was, imagine in a huge country from north to south, this was implemented with some difficulties and some inequities, but the level of vaccination, for example, has been pretty high. So this has been hardly fought for health to be a human right and to be of access without for free. So this is a political, again, a political movement that we are fighting for. And primary healthcare is at the center of this discussion, because it impacts so many different levels of funding and services and infrastructure and innovation and all sorts of technologies and actions. So in Brazil, this was fundamental for people survival, because you can imagine, I think it's around 78% of the population in Brazil don't have access to private healthcare. So 78% of the population would be without any health services, and we can imagine the even bigger disaster that we would have if this wasn't organized. But again, it's been dismantled, systematically dismantled, right, in order to privatize. So primary healthcare is at the center of this discussion and implementation, and you see both sides, they're fighting of efficiency and the whole state action discussion, or the universal right to health. So in terms of health workers, this was fundamental because they were at the front line of all this work. So and health workers are basically the majority women. So again, women at the forefront of caring for others and themselves. So there's a lot of interesting studies coming out, of qualitative studies. So we can see the level of impact. Like I think it's been said, we don't know yet how big the impact is in Brazil, other developing countries. It's very, very deep repercussions now of what happened and what's still happening, right? Because it's not over. So yes, primary healthcare is a really important discussion.
Thank you so much. And I think it's really interesting for us to hear about the way healthcare is delivered in Brazil, and which is really very different from here. So I'm curious, we probably have time for one more panelist response about primary care, if there's anyone else who wants to jump in.
This is super brief, but I would just also advocate for the addition of health navigators and paraprofessionals who are community connected into that primary health understanding, because that's really an essential piece of maintaining kind of cultural relevant responsive care that we've been talking about, as well as to healing some of the distrust issues. And there's been some work translating mental health interventions that are brief and preventative to community health workers. And I think that that's something to continue to think about and talk about in our interventions going forward.
Yeah, thank you so much for highlighting that.
I'm actually working on a project with the health departments here, and the primary care process has been difficult. It's been difficult to engage. We have a project where we're looking at opioid usage with women, particularly during this time of COVID, and the impact that has had, because there are so few resources. And it has been really tough to engage primary care physicians. I've had projects before where it seemed like it would be a great mechanism for intervention, quite frankly, because it's, I think, the safest point of entry for a lot of women. Getting them on board with doing anything that doesn't take away from or enhance their practice or enhance taking away the time and so forth here in the US is really what I think we struggle with in research. And also, you know, Sarah and I actually did a study that put this at the forefront. We were very successful once we got them on board, but it was the community practitioners that got them on board because that practitioner worked with them for a long time. So it wasn't that they wanted to work with us, it was that they actually worked with the paraprofessional and trusted that she then trusted us. So we were successful in a variety of areas, especially rural communities, more so than our urban ones. And I think that's the same thing we're facing with this project that I am on currently, is having an access point and buy-in to try something that might be helpful. That's not just, that's helpful to them and to the patient, you know? So I think it can be great. It just, the complexity around that, given what our market is for primary care here in the States, is difficult to navigate.
Yeah. Yeah, and just like any other partners, it takes a long time to understand their culture, right? And there's been a huge amount of attrition of primary care during the pandemic. So primary care doctors spend nights, weekends, evenings, you know, just barely catching up. So it's a tough group to really engage with new innovations right now. So thank you for that. I appreciate it. Thank you so much for this panel. It was really exciting to hear everyone's perspectives. I have a long list of questions, so I might send you all messages after because it was really stimulating with lots of great ideas, I think, that came out of it. So I'm going to pass this over to Sabra Klein, who's going to close and thank everybody for being here.
I am so motivated and moved by what we have brought together and the amazing work, the questions, the solutions that have been raised pertaining to women and COVID-19, with an ongoing discussion about the intersection with social determinants of health. I am grateful for the speakers from our first panel looking at the disproportionate impact of COVID-19 on women, and the second panel that we just heard from on gender responsive pandemic preparedness, response, and recovery, really giving us a lot of ideas for how to move forward. So thank you all. Next slide. I really want to thank everyone who made today possible. I would really like to start with Morgan Schur, who is serving as a program manager for our Johns Hopkins Center for Women's Health, Sex and Gender Research, as well as Patrick Shea, who manages several of our NIH-funded centers and is always willing to help. Marcus, who put together and stayed on with us this webinar. Rosemary Morgan, who is here at the Johns Hopkins Bloomberg School of Public Health with us. And this was her idea. She really pulled this together, working so closely with Dr. Crystal Coles, our new partner at Morgan State. And we are honored to have her partnering with us, hopefully not just for this symposium, but it sounds like in research efforts moving forward. Next slide. I briefly want to announce, and we will be celebrating these people at our reception later today, through our Johns Hopkins SCORE, which is one of the key programs offered through the Office of Research on Women's Health at NIH that Dr. Clayton announced. We have an opportunity in partnership with the Foundation for Gender-Specific Medicine to offer seed grants for research ideas from junior investigators specific to sex and gender differences. And I would like to announce the winners of the 2022 seed grants. Catherine Simpson, studying sex steroid metabolome and its effects on sexual dimorphism and pulmonary arterial hypertension, and James Gordy, who will be investigating the role of the chemokine MIP3 alpha fused to antigen and sex differences in vaccine-generated immunity at the level of the dendritic cells. So rather mechanistic biomedical research, but I'm equally thrilled to remind the group that Dr. Wood, who was a participant panelist in the first panel, received one of these awards for her work in Ethiopia. Next slide. I am so honored to recognize my dear friend and colleague, Wendy Bennett, who is the recipient of this year's Donna Vogel Women's Health Research Champion Award. She is an amazing colleague and an amazing champion of all things relevant to women's health. Next slide. I look forward to celebrating Wendy, the seed grant winners, and any of the panelists who can join us for an in-person reception this evening, beginning at 4 at the Rooftop Bar and Grill at the Marriott here on the East Baltimore campus. And so with that, we have hit 12:30. We stayed on time. Please go have a beautiful day and pay it forward with everything that we have learned today. So thank you so much.